кохання, але розуміє, що ніколи не може бути впевненим у випадкових партнерах. Тому Макс обирає доконтактну профілактику PrEP. PrEP – це таблетки, які не дають вірусу інфікувати організм. Їх приймають щоденно або ситуаційно до та після статевого контакту. Всесвітня організація охорони здоров'я рекомендує PrEP людям, які практикують незахищений секс, мають кілька сексуальних партнерів або партнера, який живе з ВІЛ. Завдяки PrEP Максим залишається здоровим та має свободу вибору. Він думає про себе, про нього та про неї. Подумай і ти. Обери безпечне життя зі свободою вибору. Захисти себе та інших. Зателефонуй на гарячу лінію з питань ВІЛ-СНІДу та завітай на сторінку Центру громадського здоров'я.
Колеги, доброго дня.
Good morning, dear colleagues.
Доброго дня, шановні колеги.
Good afternoon, dear colleagues. We welcome you on our final day of our conference.
І ми, мабуть, зробимо
And I think
підсумок тих
we'll do kind of, let's say, some resuming on some resume of all the topics that were discussed yesterday in the first day, and we'll switch to the further steps. So, Christina, I will start, and then I will give the floor to you. So, tomorrow we discussed all together some issues on the needs to implement the low threshold intervention that basing on community and social support, maintaining clients at PrEP, and also creating needs, raising up acknowledgements about PrEP, in particular among key groups that are not fully covered with PrEP. This is, for example, the injected drug users or sex workers and so on. And same, it is very important to implement PrEP in the penitentiary sector, and this requires intersectorial experience in international practices. Yes, Olga. Continuing with the conclusions of yesterday's discussions, first of all, we have to use modern technologies as a component of success, for example, recruiting and implementing PrEP through social networks, sites, websites of meeting people, websites, and so on. Well, from international experience and from the speakers who already presented their models on the presentation. So here I would like to draw your attention on the community-based dispensation of PrEP, so including the community services, including the communities in the services in order to establish the link between providers and clients, mapping the services and the information that should include let's say the best practices of PrEP, same from clients and providers, and also same-day PrEP law. Yeah, we also put an emphasis on that as a very important international practice that was already voiced here, and I hope that it will find its implementation as well in Ukraine. So these are main issues that we took for ourselves. And yet we got some questions still needing address. So let's consider those questions that haven't yet been addressed. So we will. What is better, to share the screen with the list of questions or just read them aloud? Yeah, what would be? Okay, I think I will start. I will start reading. First is namely, what are the obstacles of the providers when working with clients, like stigma, fear, and so on, and also key populations or key groups. So the main challenge to overcome is stigma in dispensing PrEP as well, from the side of healthcare professionals and also from the side of the clients, because the clients doesn't want to disclose, for example, their status or sexual orientation and so on. So I mean, stigma can be internal and external. For example, some clients are not ready to register themselves on ERT website for not to, as I said, to disclose themselves or information about themselves to the others. And well, this is characteristics of all the groups. And so next is low awareness about PrEP among the key groups, and same here, fear of adverse events, and then taking pills, another problem, because people don't want to consider themselves like diseased, because, and that's why there's a need of taking pills, because the one who considers themselves healthy doesn't want to take pills every day in particular. And same adherence is an issue. Here we have to work with this barrier, maybe using IT technologies. And when speaking about clients, first of all, the problem is to visit the doctor. And this is not just taking pills, but also to get tested, like HIV testing, creatinine clearance, and another barrier is the need to pay for testing. It's not everywhere one can get free of charge testing. And then transgender people to combine PrEP with hormone therapy. Next, for sex workers is fear to get pregnant due to PrEP intake. And next is the barrier contraception, the use of condoms, and also the problems from the side of social workers. Okay, I would rather stop monologizing, and Olga, now the floor is yours. Thank you. And questions, where or not we have in Ukraine the programs oriented to chemsex persons. We don't have any of that kind, I mean, services or programs covering that group of people that we have so-called like spot project, like drugstore project. implemented by Alliance, and
які якраз направлені
they provide services
серед і споживачів рекреаційних
for
напрямків,
HIV prophylactics,
і в рамках цього
namely
послуг
people
виявлення
who use injected
знову ж це
drugs
така
and
нова
so on.
група,
And same, this is a new
нас і
group for us,
мають бути
new key group, and
організовані і розширені, тому що ми
we need to optimize those services because we see that there is a growing tendency of people, chemsex people, and they should receive the adequate prophylactics. And also, there's a question about the possibility to start PrEP same day PrEP.
Розглядаємо це як необхідне впровадження вже найближчим часом.
And we think that it should be an urgent response to that. But here, first of all, logistics is the key component, is to get quick HIV testing, creatinine clearance testing. Since we implemented social support, I think we can use logistics to help our clients in testing, to do timely, to prescribe timely PrEP. To this, yes, it's first of all, it depends on laboratory location where clients can do the testing. And there's another question on interaction of TTF-FTC PrEP and hormones for transgender people. Again, we put an emphasis that PrEP is a very good approach in HIV prophylaxis, and WHO and other agencies recommend to use PrEP for those people who stay on hormone therapy. And yes, those people should be adequately consulted and supported from the side of medical doctor. And any hormone therapy cannot, let's say, be an obstacle to take PrEP in case, in particular, a person stays at high risk of HIV infection. Sorry, Christina's mic is off. We cannot hear you. Christina?
Христино, вас не чутно.
Christina,
Вас не чутно, щось.
your mic is off.
Але от кажуть теж. О, супер, чутно.
Перепрошую. Супер, дякую, дуже перепрошую. Так.
Sorry, yes, there were lots of questions on how to implement PrEP in penitentiary sector. This is totally new intervention for us. We don't have yet any experience in there. So far, we have a pilot project ongoing, and yet we have further studies and research. And we've got question on how many cases of HIV infection we can prevent if we reach 100% coverage. For example, our planning, we plan for 2023 to reach 400 people coverage. But again, in order to answer this question, we have to implement some indicator on what is really enough to reach the full prevention, 90% or 100%. This is yet to be discussed. So for the access to the penitentiary facilities, yes, we got some problems with official access, but now this problem is has been legislatively resolved together with Ministry of Justice and Ministry of Health, and now the Global Fund project have official access to penitentiary facilities. So this issue is resolved so far. And how many people stay on PrEP among those who stay within penitentiary facilities? 2021 is the year where we plan legislative amendments incorporation. So the actual use of PrEP will start from the next year. Concerning the indicators, I already voiced the main figures from the project that is provided by 100% Life. Yes, we will get additional indicators like the number of users among the PWIT, and the eligibility criteria is HIV status, high risk exposure, next absence of clinical contraindication, willingness to take up this program, risky behavior, and so on. So basic indicators, and we should also work with stigma and discrimination among those who are in penitentiary facilities, but we have to resolve this issue through the information campaign in the penitentiary sector. We have to include these components in our pilot projects and also to involve social workers in these activities. And this is an issue for discussion, and we see the high interest and good advantages in this area in order to proceed with further intervention in this area. Yeah, we talked a lot about this topic, and well, I will finalize my speech in there, and let's move forward. Do we have any other questions, Olga? Yes, we've got a question as to the best practices or recommendations on involving women at risk of HIV infection into PrEP. And also, yes, we've got a discussion about that yesterday, but this intervention let's say we don't have enough experience for that. Here we can involve experience from the work with index partners, or to integrate PrEP in the projects oriented to women, for example, who stay at risk of violation or bullying, and also involve sex workers And it is very important, I think, to make it as an individual topic, a topic apart that needs a separate discussion. Why? Because we understand that women, in particular, who don't follow in any of key groups, they let's say say they like lost because they are not involved in any key population, and that's why we have to work in there in order to provide this PrEP to women who need it. So that was the last question from my side.
Будемо готові передавати слово з нашим сьогоднішнім.
Yes, and we are ready to give the floor to our moderators. And today, yes, we welcome our colleagues who were quite active in the previous days.
Декілька
We
так. Справді дуже активними, правда?
yes, very active.
Віталія Андерса, який є, крім того, що інфекціоністом, він також працює
Dr. Anders is an infectionist, and he works in PrEP since 2017. He's one of the inspirers of the direction.
Віталій дійсно такий
He cooperates with the Public Health Center, and Vitaly is a flagship of the direction among various programs of HIV services. And today he will moderate the conference along with our very good long-standing friend, Yanis. Yanis, if I pronounce your name correctly, I do it for the last
You're one of the very few people that pronounces it always correctly, Olga. So good morning, good afternoon, good evening, everybody.
Так, Яніс з 2015 року.
Since 2015, Yanis, along with the World Health Organization, is involved in the development and implementation of all the main documents that regulate pre-exposure prophylaxis. This is the most direct contact. It's the first source of this activity. Yanis also helps Ukraine to implement pre-exposure prophylaxis since 2018 as a consultant of the WHO. And last year, with Yanis, we also had a workshop on this matter. Therefore, he has sufficient understanding of the context of our country. And we are grateful to have this opportunity to have Yanis with us. Thank you for this nice introduction. And also I would like to thank for the summary of the last day, of the previous day of the conference. Indeed, practically, there are 300 participants. I would like to congratulate on the occasion of the third day, which is the final one, and we shall discuss global coalition for implementation of PrEP and next steps for implementation of the program of pre-exposure prophylaxis. We do understand this conference is Ukrainian International Conference with international participation, and we are the integral part of the global coalition for implementation of PrEP. Therefore, Yanis, you have the floor. I would like to thank the colleagues who have introduced us.
Well, thank you very much, Vitaly. I think everybody can hear me. Delighted to be moderating this today's session, the third and final day of this wonderful conference with you, Vitaly, and thank you to Christina and Olga for your overview and recap from the past yesterday and the past 2 days, and very excited to be this effort in demand creation and actually making PrEP realized across Ukraine. But the flavor of this conference is both national and international. So we have friends and colleagues who are, making a wonderful effort in participating over the past 3 days. And it's really wonderful to have these authorities join us. I also just want to encourage everybody to share the YouTube link, which I posted above. We really want to have, we have a great online presence. We are in a pandemic right now, and this meeting is not happening in person. And really, let's just utilize our online platforms. With all that said, really looking forward to today. We're going to try to stick, of course, to the agenda. So we're a little bit 5 minutes over. So let's get to our first presenter, who's joining us in a very early morning, and we're very appreciative, Dr. Keith Sabin. His presentation has been recorded. And a little bit about Keith, who's a friend and colleague. He's a senior advisor for epidemiology with the Strategic Information and Evaluation Division of UNAIDS here in Geneva. He is an authority on HIV surveillance. I think many of you know of Keith's work and contribution to the HIV response. And he began his career back in New York City, worked for the U.S. Centers for Disease Control for 12 years, and then came to Geneva working for WHO and now at UNAIDS. I think what's also critical to Keith's expertise is also his work in many countries in other regions beyond the U.S. and Europe, including in Vietnam. So I think with no further ado, I give the floor to Keith to talk to us about setting goals for scaling up PrEP in key populations using local data. And so the floor is over to Keith. Thank you very much.
Dobry dzień, kolegi. Good afternoon. Today, I will describe to you an approach to estimating the need for pre-exposure prophylaxis, or PrEP, among different key populations. The approach uses empirical evidence to establish the number of people at substantial risk of acquiring HIV. We often ask, will people at substantially higher risk of acquiring HIV choose to use PrEP? Our challenge is often to define and identify those people at highest risk without stigmatizing them. At the same time, we want to minimize the number of truly low-risk people who take up PrEP, largely to maintain cost effectiveness. Now, there are many steps to establishing a successful program, but in this talk, we are just concerned with establishing the number of people at substantial risk, not how many want it or how many can readily access it, but how many should have it in order to have an impact on HIV transmission. To do this, UNAIDS developed a guideline that provides a framework to make these estimates. The guide provides resources to develop risk criteria and a workbook which will manage the calculations after local data are entered. The guide does not offer help with cost effectiveness or recommend a specific screening tool. The information used and the outputs can, however, help with the development of both, as well as give some ideas for scaling up PrEP programs. Now, how can we estimate the number at risk? In this simple schematic, we multiply total population size by the proportion at higher risk of acquiring HIV to give us the number at risk. The next step, however, is to apply this approach to the HIV negative population only. So we require an estimate of the number of key populations who are seronegative. Now, we have narrowed our perspective to look at HIV-negative individuals who have a substantial risk of acquiring HIV. This list on the slide is a potential set of exposures that could be considered as a set of criteria. In the guide, we have also included a review of risk factors for each key population. The most useful risks are those associated with incident HIV infection. In the absence of available incidence data, factors associated with prevalent HIV can be used instead. However, when there are local data available, these data should be used in the worksheet. In general, we see risks as either proximal or distal to the likely route of HIV transmission. In the example for men who have sex with men, unprotected anal intercourse, or UAI, as it's written on this slide, is the most consistently associated risk. So a team can decide on a set of risks to choose among 3 categories of risk, those being high, medium, or low risk. But in each case, unprotected anal intercourse is included in all of the configurations. So you can see for a high risk per individual, or the proportion, it would be those with an STI, a sexually transmitted infection, in the last 6 months, or more than one partner in the last 6 months, or UAI in the past 6 months. Once the risk criteria are established, the workbook takes into account these factors and does the math. Beginning with the population size, which is multiplied by a projection factor if it is an older population size estimate, which is then multiplied by the proportion of the population who are HIV-free, which is then multiplied by an inflation factor if you determine that surveys are biased toward one or another subgroup. And finally, the product of all of that is multiplied by the proportion at substantial risk as determined by the locally established risk criteria. In the workbook, these tools are available. An estimate summary sheet, population projection calculators, risk factors documentation sheets, and minimum risk behaviors calculators. This is the opening page to the workbook, and the team undertakes the workbook. They must fill in each of the green boxes here. Some of the boxes are to provide metadata, some of the boxes accept actual data from your locality. So here are the metadata. Here's an example of metadata at the top of the screen. So this is about men who have sex with other men, and it's the operational definition that was used is for in the last 6 months, and the men must be 18 years or older. And then the team can input each of the data for each of the green boxes. The blue boxes are then calculated by the program. Once the team agrees on all of the data that go to these inputs, the number at risk come out at the bottom. And there are different calculations for high, medium, and low risk if different sets of criteria are used in the worksheets. Now, this tool will be available in its entirety on the UNAIDS website in the very near future, but I've also put an access link to the files below, so when the slides are shared, you'll be able to click the link and access these slides and the workbooks and the tool that will explain to you how to use those workbooks. Thank you for your attention, and I hope that this has proved informative for you.
Great. Thank you very much, Keith. I know it's really early over on your end, and thank you for that great overview of UNAIDS guidance on target setting, which, as some of us know, actually has already been utilized in some countries, including in Vietnam and Thailand as well. And so there's been, as my understanding, a consensus sort of exercise in target setting for those countries. And so maybe if you can I'll kick off a question, you well highlighted that, this methodology is looking at those at substantial risk who would most benefit. But then you have also cited the 3 layers of higher risk and then moderate risk. And so I think for a country like Ukraine, and as we embark in thinking about more ambitious coverage, right, and having a better steering direction based on a methodology like the one you guys at UNAIDS have developed, maybe if you can give us some some practical advice as to how to deal with, of course, thinking about those at highest risk, and you well demonstrated there's some risk factors that are really well known, like condomless anal sex, rectal gonorrhea in MSM. But how to maybe also think about targeting those that under that highest risk threshold, those in moderate risk, and really for not just key populations, but also serodiscordant couples. So it's a loaded question. So it's over to you, and maybe you can reflect from your work with Thailand, Vietnam, and other countries. So again, thank you, and I know it's really early on your side. Thank you, brother.
Oh, it's fine. The advantages of jet lag are that I'm
and you have a
early.
Beautiful haircut, but you look fabulous either way. Over to you.
Yeah, I look a little different from the video. There are a few challenges in this, because I think what we've, in the 2 exercises that we've done, I think the most ardent arguments were made over how to establish different levels of risk. And I think some of the tension there is between those who want to cover as many people as possible and those who are saying we can't afford to cover as many people as possible. So let's start with those people who are at highest risk. And I think that is a very practical approach. Even in that context, let me emphasize that everybody who wants to access PrEP should have access to PrEP, regardless of their risk. So, I mean, they should be counseled away from it if they're monogamous and et cetera. But it should be available to all, whether it's high or medium risk. I think in a place like Ukraine, you have some heterogeneity of risk across the country. You have much higher risk in the East than you do in the West, particularly around for people who inject drugs. We know a lot less, or I should say, I know a lot less about men who have sex with men in Ukraine. And I think the data I've seen is a little more limited, both in length of time that those data have been collected and what's generally been available until the last couple of years. So it's a little bit more difficult for me to speak about the heterogeneity of risk among that population. But what we've done with this tool is simply to allow, in this case, each oblast could approach it based on the risks that they've already identified using their routine biobehavioral surveillance system. So the data exists, you have a sense of where the risks lie, and then you can start to look at it from that angle. I think the other challenge in a country like Ukraine, particularly again with people who inject drugs, is it's such a long-standing epidemic that you have a lot of people living with HIV, again, among people who inject drugs, and those people need to be removed from consideration for PrEP. And that's also been part of the challenge. Again, knowing less about the population of men who have sex with men, it's a little more difficult to establish how many people are already living with HIV who remains and who among those who remain are at highest risk. So we did do an exercise within UNAIDS to establish global targets. And so we have data from Ukraine because it is such a data-rich country. And just looking at the numbers that we used for men who have sex with men, using published data, we established a target for medium risk men who have sex with men for the country of 220,000. And the plausibility bounds around that were between 170 and 260,000. So that's our back of the envelope, not doing it oblast by oblast, but using a national approximation. And the high risk group was about 93,000. And that's just men who have sex with men. I'll just shift briefly to serodiscordant couples. I haven't seen data for that from Ukraine. This is a challenge everywhere we go. The only countries that have really strong serodiscordant data are those with household surveys. So the only place we've been able to look at this is in sub-Saharan Africa, where they've had recent door-to-door household surveys. And those numbers are reasonably substantial. It's really difficult to establish risk because if the person living with HIV knows their status, there's a strong likelihood in many of these countries where we do these surveys that they're already on ARVs. And if they're virally suppressed, there's no need for PrEP. And so the challenge in modeling a target for serodiscordant couples is much greater than it is for key populations because of the lack of data at a national level. I think this is something we can certainly look into, but when we looked into developing something in the way of a tool, we didn't have enough information to take it very far. So we put it aside for the moment. I'll stop there so there's time for another question.
Thank you very much, Keith. That was very clear.
Пане Кайт, дуже дякую. Дуже цікава презентація. Дуже дякую за відповідь. У нас, на жаль, ми вибиваємося з часу, але хочеться...
Answer. And we also have two short questions. I will ask one of them.
Можливо, будемо надати свою відповідь так доволі коротко.
Maybe you can answer quite briefly.
Коли ви говорите про людей, що вживають...
Can you speak of injection drug users? The assessment of the risk and the requirement for PrEP. In that case, did you assess the risk by injection, the risk by injection of drug, or by sexual way, or among the injection drug users? Because when we speak of PrEP, this is urgent for Ukraine, especially within our expansion, rolling out for the injection drug users. Thank you.
Yeah, that's an excellent question, and
Це прекрасне питання.
We do run into this question. We did a similar exercise for people who inject drugs for Ukraine, for the global estimates, and we came up with a high-risk estimate of 65,000.
І ми побачили високий ризик 65 тисяч.
And about 200,000 at medium risk.
І 200 тисяч середній мають ризик.
For the risk distribution, we
стосується розподілу ризику,
at use of routine, whether or not somebody reported 100% use of clean needles. Now we know that's relatively rare.
100% використання повторне використання шприців. Це достатньо рідкісне явище.
And if we're doing this at an oblast level, I think that you can include whether or not condoms are routinely used or whether or not there are other sexual risk factors
involved. Чи є якісь інші статеві фактори ризику?
But in most of our experiences,
В основному з нашого
primary risk for
основний
transmission
ризик передачі
is sharing needles.
це якраз
The biggest risk sexually is for the non-injecting sex partner.
А що стосується статевого ризику, це для того сексуального партнера, який не вживає ін'єкційно наркотиків.
So in essence, it would be good if we had a system for not serodiscordant couples, but injection discordant couples.
Для ін'єкційно дискордантних пар.
But if the person injecting uses PrEP, they're protecting their
ця людина, що є ЛВ, вживає ДКП, звичайно, що він буде захищати свого партнера.
Дякую. І дуже коротке питання, пане Мартін. Будь ласка, включіть мікрофон. У нас
In very short question, Martin, please switch on your mic.
Yeah, hi Keith. Good to see you.
Вітаю, Грісе, радий тебе бачити.
I think I'm getting Ukrainian and English, but okay. Let me give you the question, and of course, Keith, you know me well. My question is going to be a leading question.
Ну і хочу задати питання. Моє питання
You've probably seen the targets for Ukraine, and Ukraine actually has the biggest PrEP program in Eastern Europe, and it's a really, it's a good program. It's growing. However, the target for 2021 is 7,000 people. Target for 2022, 10,500. Target for 2023, 13.5 thousand. Are you able to comment on that, given the work that you've done, not just on the theoretical estimation, but I know that you've applied these estimates to countries like Vietnam. Are you able to comment on, what is the scale of the ambition we should have here in Ukraine? And I'm sorry, it's a very loaded and a pointed question, but thank you.
No, I think it's important. I think, recognizing that Ukraine has always been a leader in implementing and going to scale with prevention, particularly for people who inject drugs. And now I think they've been fairly open-minded about approaching men who have sex with men, because that was a group that was not recognized as particularly at risk 10 years ago in the country. Not ignored, but not focused either. Our estimates needs are much greater, even if we're only talking about the highest risk individuals. If I add them all together, including sex workers, female sex workers only, we're talking about, over 200,000 in need, right? And again, this is back of the envelope, but I think, if you're really going to bring this to scale and have an impact at a population level, the targets need to be 10 times higher than what we're seeing. Those numbers are fine for those 13,000 individuals in 2023, if you're one of the lucky few, but that won't make a dent in the epidemic across the country. So, I think ambition is critical here. And yes, UNAIDS talks about ambition as a matter of it's something they imbue in us. And so I think that we need to really encourage the country to look at this more closely, and PrEP should be as commonly available as condoms and clean needles in this population. They've done a remarkable job at the national level, but what we've seen is relative stagnation over the last few years, and that's global. It's not unique to Ukraine. And so we need new tools, and they need to be taken to scale as rapidly as possible. And I think that's my view of it.
Thank you.
Thank you very much, Keith, for your insight there. Great question, Martin. And I will I think we're going to move on to the next speaker, because we're just trying to stay in time. We're a little bit late. So thank you, Keith. And I really appreciate you joining us this morning. Thank you so much. And on your holiday.
Thank you.
So Thank you. So food for thought there in terms of what Keith described. And if anything, this past year with COVID-19 has shown us, if we are ambitious, great things can happen in public health. We brought a vaccine that was made available within a year, and we've rolled out vaccination programs for COVID-19. And now we have this tool that's, this decade of PrEP, of research and policy and programming. So now it's really thinking about how we really go to scale in Ukraine. And so with that, I will introduce our next speaker, a colleague and friend joining us from Bangkok, Thailand, the wonderful Dr. Heather Marie Schmidt. She is the regional advisor for PrEP, jointly with the UNAIDS Regional Office for Asia and the Pacific and Testing Prevention Populations Team, and also WHO's Department of Global HIV, Hepatitis, and STI programs. She is also an authority on PrEP, and I think one of her great contributions has been to the work that happened in Australia to rapidly scale up PrEP and drive down new HIV infections in New South Wales. So she's been very critical in that effort, and we also had a great presentation from Irina Zablocka from the University of Sydney on our first day of the conference. So she's really passionate about all things HIV prevention and sexual reproductive health. So she's going to give us her perspective and what's really happening in her region, which really can inspire us here in Ukraine and beyond. So over to you, Heather Marie.
Good afternoon. I'm Heather Marie Schmidt, the Regional Advisor for Pre-Exposure Prophylaxis with the UNAIDS Regional Office for Asia and the Pacific and the WHO. In Asia and the Pacific, new HIV infections declined by only 12% between 2010 and 2019. But critically, this figure hides significant variation by country and by populations within a country. While some countries have experienced declines, including Vietnam, Thailand, and Myanmar, others have rising epidemics, including Malaysia, Papua New Guinea, Pakistan, and the Philippines. Here in the Asia Pacific, our epidemic is concentrated among key populations and their partners, who accounted for 98% of new adult infections in 2019. Young people accounted for over 1/4 of new infections. Critically, prevention coverage is suboptimal among key populations. Countries within Asia and the Pacific have increasingly recognized the importance of PrEP for filling the crucial prevention gap. Several countries have started PrEP demonstration projects recently, including Mongolia and Laos, who both started this year, and Sri Lanka and Myanmar, who started last year. I also want to point out Cambodia, which rather than using a demonstration project, began PrEP as a phased implementation approach. They've enrolled over 1,000 people since mid-2019 and are progressively scaling up despite COVID-19. But at the present time, there are only a few countries with large-scale PrEP programs. Australia and New Zealand, for example, have well-established PrEP programs subsidized by the government. Thailand included PrEP under their version of universal health coverage in 2019, and Vietnam has been scaling up availability as well. While we've made some significant progress in Asia and the Pacific in terms of increasing access and uptake of PrEP, particularly over the last year, we have about 70,000 people who are estimated to have used PrEP at least once in 2020. And while PrEP uptake is accelerating, it is not proportional to either the incidence, prevalence, or need, and is too slow to yet affect the course of the epidemic. Successful programs for PrEP in Asia and the Pacific have taken a number of similar approaches. And these include opting for a client-centered and community-driven approach both to planning and implementation. So designing by and for the communities that would benefit from PrEP. Using differentiated service delivery models, including key population-led models that are acceptable, accessible, available, and best of all, convenient. Having multi-sectoral commitment to PrEP from government, civil society, researchers, implementers, donors, and other stakeholders. Using innovation and digital space, including telehealth, particularly during COVID-19, and really using empowering, fun, and positive models of care and promotions. However, there have been and continue to be a number of challenges, including cost, both of services and of the PrEP drug, insufficient expansion and availability and accessibility across a country, issues with monitoring and evaluation, service integration, away from PrEP programs and into, for example, STI programs, so sexual and reproductive health programs. Policy support has not always been as strong as we would like. Awareness still remains a challenge, and stigma and discrimination, and also laws and regulations that criminalize people who may benefit from PrEP remain challenges. So looking at these in the context of a few examples, I was fortunate to have led the PrEP portfolio within the New South Wales Ministry of Health in Australia, working on the EPIC New South Wales trial. EPIC New South Wales was a time-limited public health intervention designed to interrupt HIV transmission and reduce new HIV infections in the context of high testing and treatment and maintaining condom use. The priorities for this program included accessibility and availability, acceptability through the use of really positive promotion campaigns, quality of care, and really using all of this to achieve speed and scale in rollout. Other crucial components included partnership and planning and implementation between policymakers, researchers, community, and clinicians, who all had roles in both the planning and in implementation. Innovation was also critical. We used nurse-led models of care to increase clinic capacity, community-based testing sites, and which included peer-led testing, peer-led complementary services, including things like counseling, information, and peer navigation. And really crucial was demand generation and community mobilization that was community-led and enacted. PrEP was also available ideally where people needed it, from general practitioners, public sexual health clinics, and community testing sites, places that the community interacted with healthcare. And the program was designed with sustainability as key. PrEP was subsidised, as I mentioned, by the Australian federal government in 2018, and since then, the number of PrEP users has only increased. And measuring the impact of this program has helped to justify the investment and ensure transparency and accountability. We've seen continuing decreases as PrEP scale-up continues to increase. In 2020, there was a 36% decline in MSM, who are the main beneficiaries of PrEP, the main PrEP users in New South Wales, and a 37% decline in recent infections in MSM. And recent infections are particularly important to measure because they're the ones that you're hoping to prevent with PrEP. And these figures are compared with a 5-year average. In Vietnam, there were clear community preferences for how PrEP should be delivered, including preferences for key population-delivered PrEP. Prepped for PrEP was the first PrEP demonstration project in Vietnam, launched in 2017. And since that initial project, PrEP has expanded to over 27 provinces in the country. In 2020, Vietnam's PrEP program dramatically expanded and was able to deliver PrEP to over 18,000 PrEP users, more than 10,000 more than the year before. And this is despite the ongoing COVID-19 pandemic. Civil society and innovation are hallmarks of the Vietnamese PrEP program, and as is a multi-sectoral response, again with involvement of key partners across civil society, government, research, donors, and implementers all collaborating together. Key population-led clinics, as I mentioned, were not only important preferences for the community, but have become important delivery points for PrEP. And these PrEP services were subsidized, but not completely free, with a small fee contributing towards the cost of PrEP. To protect PrEP during the COVID-19 pandemic and ensure continuity of services, Vietnam took a number of steps to leverage off their existing innovations, including things like online counseling and telehealth, PrEP drug delivery, and home-based lab sample collection, including the use of blood-based HIV self-testing. Vietnam's PrEP scale-up program was approved in December 2020 and aims to provide PrEP to over 72,000 individuals, setting a new benchmark in the region for scale and speed. In the Philippines, PrEP is beginning to expand, and it provides a very important example of what can be done by clinicians and civil society working together. The CBO Love Yourself originated the project PrEP pilot project in the Philippines. The model similarly used a friendly community-based setting and task sharing with peers for activities like PrEP information, counseling, and eligibility assessments. And now that the PrEP pilot has finished with excellent results in terms of acceptability as well as self-reported and objective adherence, PrEP rollout has focused much more heavily on the client-centered, peer-driven, and differentiated approach than ever before. During the expansion, they have now streamlined consultations, making them shorter, which allows more clients to be seen and reduces the burden on a client. They have integrated PrEP with other online activities, increased demand generation, and creating safe online spaces. And you can see examples of some of the PrEP promotional campaigns, #Men of PrEP and Queens of PrEP on these slides. And they've also expanded critically the access points, not only through Love Yourself, expanding the number of sites, but also through other CBOs and private practices, as well as online access points and diagnostic facilities for diagnostic tests. And WHO is currently working on simplifying PrEP guidance to make it easier to take PrEP and easier to provide it. For example, time to stop, the essential PrEP package, counseling on effective adherence, service delivery models, including the type of staff that could screen, initiate, or follow up for PrEP, the mix of PrEP locations, and entry points for services, as well as opportunities for service integration, such as STI services, SRH services, key population services, and harm reduction services are all possibilities. What we hope is to release this new guidance at the end of the year to really improve and expand access and uptake of PrEP. So the Ukraine has an important opportunity to be bold and to be brave with the rollout of PrEP at scale. If there is some advice that I can provide, it is to target well. So knowing your epidemic and acting on it with where you're providing your PrEP services and how you're providing them. Listening to the community is key. Aiming for high coverage is important for both PrEP and for the individual and population benefits to be realized. It's important to diversify, demedicalize, simplify, digitize, and integrate PrEP services. Consider what services could offer PrEP. There are examples from Asia and the Pacific that could help, including community-led and key population-led services. What innovations are required to increase PrEP uptake and reach, including digital space innovations, models of care, and demand generation activities? It is important to plan with sustainability in mind, and that's why I brought up the example of Cambodia, who have taken a phased implementation approach to PrEP, planning forward into the future. What's really critical is that the rapid implementation of PrEP can produce rapid results, and we've seen this in places like Australia, and the modelling and real-world results show that it really can be done. I want to thank the organisers and everybody who contributed to this presentation, and also provide a shameless promotion for our upcoming PrEP webinar on community-led PrEP promotions and campaigns on the 7th of July, which will provide even more examples of how the community can lead and champion PrEP strategies for raising awareness, acceptability, uptake, and effective use of PrEP.
Great. Thank you so much, Heather Marie. Fantastic presentation. I think wonderful lessons that we should all learn, not just in Ukraine, but in other countries. I think you kind of completed your presentation there with the notion of rapid scale up can equate to rapid results. And I think that's, where we can, really can find ourselves. I think we have time for a question because we're going a little bit over time. And if you can stay with us for kind of the discussion, we'd appreciate it. But Martin Donahue has his hand up. So I pass off the floor to him to ask his question.
Thank you. Let me put my video back
У
on.
нас єдине, я хочу сказати, у нас є час на одне коротке запитання. На жаль.
The only thing I would like to mention that unfortunately we are really much behind our timing, and we have time, but only for one question, just one question. Martin, maybe just a short question from you. And
Yeah, thank you. I've got so many questions to ask you, but let me just ask one critical one, which is going to be really important for our Ukrainian colleagues. In Vietnam, 72,000 people on PrEP. In Ukraine, we have a target of 7,000. One of the big concerns in Ukraine is the cost of this intervention, Heather. And can you give us, it's a very bureaucratic question, but something quite important. What is the cost per client for this intervention and the cost effectiveness?
So let me start with the cost will vary depending on the country. There are a number of factors that play into the cost. And of course, the cost in country will therefore influence the cost effectiveness in any country. So the major things that have influenced cost effectiveness in the past have been, or the predominant driver of cost effectiveness has been the cost of the drug itself. Mm-hmm. Now, we know that the cost of the drug itself has declined dramatically over many years. And so really from the Global Fund, the cost of the PrEP drug is now $3.55. It might actually even be lower this year. So it is really quite low. And so that's for TDF-3TC, which is perfectly acceptable alternative to TDF-FTC. But you're looking at less than $5 for a bottle of 30 pills. And now then you also have to look at some of the other costs that would go with this. So from a minimum point of view, you're looking at an HIV test to start, ideally one at 1 month, and then every 3 months. HIV, best practice for anybody who's at risk for HIV is to have regular HIV testing. So this really is just bringing people in for something that they should be coming in for anyway. So I think it's really important to remember what is additional for PrEP and what is actually just best practice for people who are at risk for HIV. And so I'm not sure what the Ukrainian guidelines are. In Australia, it's every 3 months. In many countries in Asia Pacific, it's every 6 months. So you're really looking at maybe 2 additional tests a year. Maybe. And indeed, best practice might be those 3 tests. So then you're looking at some of those other things you need to. We are, as I mentioned, we're also looking at simplifying PrEP from WHO and looking at what that minimum package is to deliver PrEP. So it really depends on what that minimum package is. We're revising the guidance on creatinine to also to make this a little bit easier, and guidance on we're looking at the guidance on hepatitis testing. But if you look at just the cost of the drug plus the cost of the consultation, again, your costs in terms of finding effective and efficient models of care. If you have very simplified, shorter consultation times in line with the need of the patients, then you're going to be obviously able to see a lot more people. You need fewer people in the clinic in terms of providing care. So there are lots of ways that you can reduce costs without reducing quality. And you can still provide a really quality experience for the provider as well as for the client, and still provide quality care that's safe. And that's where demedicalization is incredibly important. Where a doctor tends to be quite expensive, but you've also got other allied healthcare workers and other clinicians like nurses that are in much greater supply. It's much more interesting for a nurse to provide PrEP than it is for a doctor. Most doctors, it'll be completely boring and not interesting at all. So there are really, it's a very long way to say you can do this much more efficiently, much cheaper, with a little bit of innovation and a little bit of thinking outside the box. And all I can say is that there are many countries that have implemented PrEP at a large scale, including places like Australia, much of Europe, the UK, and other places. They've all done the cost effectiveness studies. Thailand introduced PrEP under UHC. And one of the things that we looked at was cost effectiveness. And so, we can say that the savings that you get and the impact of PrEP have enormous benefits, but every analysis will be very much based on the unique country context. But I would say it can be implemented in a way that is cost effective.
Дякую. Дуже дякую, колеги. Надзвичайно дякую вам за презентацію. Надзвичайно цікава презентація.
Thank you, colleagues. Very interesting presentation. And I would like to mention that we have over 300 participants. Please write your questions in the chat. We'll try to address your questions right after the presentation or later, because we're much behind time. And thank you very much again for your presentation. All the questions, please write to the chat. And we have more speakers. They can answer your questions in the chat. And now I would like to present our next speaker. This is Dr. Ezra Barzilai.
He is the director of CDC Ukraine, and he works for CDC, and he has vast experience in CDC since 2004. He is a patriot of Ukraine, and he speaks for equality, equal access for the key populations, and he is a participant of several. He's a participant of several Odessa, Ukraine campaigns for equality marches, and also Ezra focuses a lot of efforts on pre-exposure prophylaxis in Ukraine, and he loves Kyiv, and also he likes the Kyiv subway, to travel by Kyiv subway.
Good morning, good afternoon, and good evening. My name is Ezra Barzilai, and I'm the director of the Ukraine office of the Centers for Disease Control and Prevention. It's my distinct pleasure to be here with you today on behalf of the interagency team of the U.S. President's Emergency Program for AIDS Relief, or PEPFAR, and to share with you the vision for the future of PrEP in Ukraine. Since the approval of PrEP in Ukraine and with the support of international partners, Ukraine has undertaken ambitious targets for the scale-up of PrEP availability nationwide. PrEP in Ukraine is still a nascent program that started with modest targets of 3,000 clients in 2020, and which now aims to have up to 11,000 clients by 2023. PEPFAR and the Global Fund will, of course, continue to support the program in its bold growth plan, but program implementation is not solely about setting targets, which is why I call the program the growth plan bold. This type of scale-up requires careful planning and coordination. It's not sufficient simply that PrEP become available. It's also necessary that we stimulate sufficient interest through demand creation for the rapid increase in PrEP uptake from 2020 to 2023 to become a reality. Currently, the majority of clients on PrEP or those that are a good target audience for PrEP live in the 12 PEPFAR-supported regions shown on this slide. So now the question at hand is, how do we go about creating demand? Well, the first step is to make PrEP more widely available by increasing and by diversifying the PrEP entry points. The PrEP program in Ukraine began with CDC support in 2017 in Kiev City with a single facility, the Kiev City AIDS Center, and a modest target audience of approximately 100 MSM clients. At present, we have 66 facilities that are providing PrEP services. And by the end of 2021, our plan is to have PrEP in each medical facility that has contracted with the National Health Service of Ukraine, ranging from large AIDS centers to small rayon hospitals. Keeping with our ambitious growth plan, our goal is by the end of 2022 to make PrEP available at both NGOs that provide care and pharmacies. The second step in demand creation is to increase awareness about PrEP. A recently released results of an integrated biobehavioral survey among people who inject drugs conducted in 2020 revealed sobering results. In large urban centers such as Odessa, Dnipro, Kharkiv, and Kropyvnytsky, less than 5% of respondents knew what PrEP is or were even aware that PrEP is an appropriate HIV prevention option for PWIDs and that it is available to them. Even on the other side of the spectrum, in Khmelnytsky and in Cherkasy, where the questions pertaining to the awareness of PrEP in the survey, which returned the highest scores, only 1 in 3 people surveyed reported knowing what PrEP is or how to access it. Obviously, if we do nothing else, we need to make public health messaging and a PrEP information campaign a strategic priority to ensure that PrEP is well known among all of our vulnerable populations. Next, I would like to introduce you to our programs which were designed with our specific client populations in mind. For our MSM clients, we offer different models of PrEP. For example, the standard daily PrEP, as well as what's known as event-driven PrEP, also known as 2+1+1. I'm not going to go into these in great detail, as I'm sure they will be covered in other parts of this conference. We cover the costs for hepatitis B and creatinine testing, and we have just launched a targeted advertising campaign aiming to increase awareness and to generate demand. For our population of people who inject drugs, we have introduced a referral system for clients who are at a high risk of HIV acquisition and who tested negative for HIV at our OCF and MCF project sites. These clients are immediately enrolled in case management to ensure effective linkage and retention to the PrEP program. They are also tested for hepatitis B, creatinine, and they also receive non-monetary incentives such as transportation costs, cover of additional examinations, food and food packages, just to name a few. We also offer psychosocial specialized support to help those with IV drug and rehabilitation when and if needed. And we have launched a different targeted information campaign to increase awareness and to generate demand among PWIDs. Another important population that we engage with and we provide services to are our PrEP serodiscordant couples identified through our index testing programs. PrEP is recommended for index partners who tested negative until the viral load suppression of the HIV positive partner is achieved. Once viral load suppression is achieved, there's no sense to continue PrEP, as following the U=U guidelines, HIV cannot be transmitted if the HIV positive partner is virally suppressed and has an undetectable viral load. And looking to the future, we are considering PrEP for commercial sex workers as a potential area of support starting in 2022. Now, I'd like to shift gears a little bit and take a closer look at the PrEP landscape in the PEPFAR-supported regions. As you can see, the path to ensuring successful implementation of the PrEP provision is a collaboration between government, local, and international partners. The Public Health Center of Ukraine, our national implementing partner, works on the development of enabling policy for PrEP, serves to provide coordination at the national level, is responsible for the PrEP supply chain management, as well as for the monitoring and evaluation reporting. The Alliance for Public Health leads the charge of providing social support for approximately 2,500 PrEP clients and works on proactive client referrals for those who are at substantial risk for HIV acquisition through their testing projects of OCF and MCF. ITEC supports the 39 largest ART sites, focuses on institutionalizing the implementation of event-driven PrEP, which is known as PrEP on demand or 2+1+1, as well as conducting healthcare worker education and outreach. The Network for People Living with HIV, known as 100% Life, is supporting PrEP delivery at the regional level and conducts advocacy for PrEP at the national level, as well as providing social support for MSM clients. And last but not least, at the regional level, we have our multidisciplinary teams who coordinate PrEP implementation in the regions, develop and streamline the patient pathways, and provide technical assistance to the PrEP sites that they oversee. And of course, behind the scenes, WHO, UNAIDS, the Global Fund, USAID, and CDC do everything we can to keep the program running smoothly. On the policy front, the Public Health Center of Ukraine, with the support of PEPFAR Ukraine, has made significant progress in developing an enabling policy environment for PrEP. In February of this year, the Ministry of Health of Ukraine approved a newly established national PrEP guideline, which outlines both the standard PrEP use and introduced the PrEP on demand model. Additionally, the provision of PrEP was included in the National Health Center of Ukraine HIV services package, and starting from April 2021, PrEP may be prescribed by any medical facility which has contracted with the National Health Service of Ukraine. And finally, after approval of recent amendments to Order 585, PrEP may now be prescribed by generalists and not just by infectious disease physicians. Now, no vision would be complete without taking a closer look at the existing gaps and asking ourselves, where is there room for improvements? In fact, there are several areas that we plan to focus on in the near term. One, despite ambitious goal setting, the actual scale-up has been too slow to show, as of yet, a statistically significant impact on the HIV epidemic. Second, presently, the actual PrEP medications are not procured by government of Ukraine funds, but through the support of international donors. 3, PrEP is currently available only at HIV treatment facilities, although we're hoping that this will change soon. 4, the pharmacological landscape for PrEP is ever evolving. There are several new models being implemented in Europe and in the US, such as long-lasting injectable PrEP or dapivirine, which is a known NRTI, which, however, now can be administered in the form of a vaginal ring. Unfortunately, these are not yet being considered in Ukraine. We plan, however, to support this issue by transitioning the procurement of PrEP from donor support to government of Ukraine funding by the end of 2023, support amendments to the legislative framework to permit the rollout of PrEP in pharmacies and NGOs providing care, and by advocating for the implementation of new PrEP models and by assisting the development of effective M&E systems for PrEP. Finally, I would be remiss if I did not address the elephant in the room. The results of the IBBS revealed what I consider to be a critically insufficient level of awareness about PrEP among KPs, as well as among healthcare workers. If we're being honest, it's not reasonable to expect that we will be able to create substantive demand around PrEP unless we first support the development of an informational material campaign about PrEP and disseminating widely. With this goal in mind, we are launching a series of targeted advertisements across social media, web services, and other internet hotspots, tailored specifically to the socio-demographic profiles of potential PrEP clients. In 2021, our partner, the Public Health Center of Ukraine, developed a PrEP national brand and created a national landing page where potential PrEP clients can receive detailed information about what PrEP is and where to find it. All the while, we continue our collaboration with the National HIV Hotline, which supports promotion of PrEP among their client base and works on PrEP demand creation and proactive referral of clients on PrEP. It's an exciting vision for PrEP in Ukraine, and much has been accomplished in a short few years. But as you can see, there's still much work ahead. Thank you very much for the invitation. I appreciate taking the opportunity and the time. And now I will be happy to take any questions you may have. Thank you.
Езра, дякуємо за таку чудову презентацію, обширну презентацію, бачення підтримки.
Thank you for this presentation, as well as the vision of support of PhAR to Ukraine. I would like to briefly ask a question. What is the vision? What is a recommendation? We discussed the important role of social support and the non-government sector and partners. If we speak about 100% of clients, which number of clients should be covered by service? Do all clients require social support? If we speak about de-medicalization, doesn't it mean that it's better if you have less contacts with doctors in HIV center, and then we need to cover the clients with social support?
Thank you, Vitaly. I'm not sure I understood entirely the question, since I've had the floor for a quick second, I preemptively apologize from.
Чи маємо ми пропонувати соціальний супровід і надавати
Shall we
соціальний
propose social support to 100% of clients?
Okay, I understand your question now. Thank you. So I think that's a matter of approach, to be honest. I mean, I think that it'd be obviously helpful if we had infinite resources to do so, but I think we need to prioritize which clients are most likely to need support, either to access, to be in a place where they'll be able to take PrEP and retain themselves on PrEP, and will not, I want to reiterate, and I know it's been discussed a little bit throughout the last couple of days as well, that PrEP is not a magic bullet. I mean, yes, it's the closest that we have to. I think Yanni said it's the closest we have to an HIV vaccination, right? It's a prevention mechanism, but that doesn't absolve us of the need to also make sure we don't engage in the highest possible areas of risk acquisition as well. So I think that we need to focus. We need to be a little bit mindful and focus our psychosocial interventions and support specifically on those patients that are unlikely to stay on PrEP, to be able to maintain their access to PrEP, or just to maintain their access to healthcare altogether. When dealing with a KP-focused epidemic, there are niche populations, even within the communities we address, that need a little bit more support than others. And so, yes, in an ideal world, everybody would have the psychosocial support. I think that one's posture and one's experience vis-a-vis HIV and their decision to basically take a preventive stance against it is something that should be discussed. The patient should have the place to basically echo these sentiments with somebody. Given that we have a lot of needs and there's a lot of asks on our psychosocial support resources right now, I would say that we should probably think through how to more carefully apply ourselves and find the patients that need it the most and prioritize them, because we want to make sure that our PrEP is not only accessible widely, but also effective, meaningful, and has some longevity to it as well.
Dear Ezra,
Дуже дякую, пане Езро. Колеги, маємо рухатись далі. Будь ласка,
Thank you very much indeed. Shall we move forward? If you have questions, please write on the chat. We shall do our best to answer after the speeches, after the presentations. Now I would like to introduce the next speaker, Madam Oksana Danilenko, the doctor and advisor on clinical and strategic issues of ITEC. I know that most of Ukrainian colleagues know her, and of course their team supports the implementation of SOPs as a level of healthcare institutions, as a level of sites, and she will share the information, and the presentation will be coverage with PrEP based on the best international practices and services of ITEC in Ukraine. Please, you are welcome.
Good morning, dear participants of the conference. My name is Oksana Dalenilenko. I'm advisor on strategic issues of PrEP in Ukraine, and today we will speak about the expansion and coverage with PrEP on the basis of the good international practices in Ukraine. In my presentation, I will present you the short information about ITEC. We will talk about the launch of PrEP program along with the best practices, standardization of PrEP on the basis of the health facilities, the approach to training in PrEP, and we will see our intermediate results and plan for the future. International Center of Education in ITEC is a part of a University of Washington, and it was created together with California University in San Francisco. ITEC works in 16 countries of the world, and our highlights are, first of all, the prophylaxis in providing health services. The aim in Ukraine, first of all, to cover with PrEP services on national level as well on the health sites. We work in 11 regions of Ukraine with the highest spread of HIV. The intervention, according to the best practices, required the express assessment of the health sites. We know that this assessment has a key importance within the implementation of the health programs. In April last year, we did this assessment with the use of survey that was distributed through email. 37 out of 39 health sites took part in this survey. Some of them have already the local protocol or patient route on a PrEP, and the others reported about the necessity in additional education and training. Among them, they got different criteria for patient selection for PrEP that reveal the need for standardization of providing services in PrEP. What does it mean, standardization? This is the standard operating procedure by definition of the Public Health Center of Ministry of Health of Ukraine. This is a tool or a set of instruction for specific type of services to standardize the procedure in order to reduce the probability of error. So we developed SOPs for the daily services for clients as well as for on the basis 2+1+1. We adapted these SOPs for their approval for use in regions. So the objective was to standardize the provision of services on the framework of the health facilities, in particular in view of the lack of medical standards. So we considered that these SOPs that could be recommended to implement in all regions of Ukraine. The lack of knowledge is really a very important issue. Without that, we cannot start the implementation of PrEP. Using the data from US studies, so the knowledge of the PrEP in practice in it, evidences about the great significance of training and acknowledgement of those professionals who will implement PrEP. Plus, they should be willing to do it in the future. In order to educate our doctors, we decided to involve experts already having the experience in PrEP and that will promote this intervention among other physicians and resolve the different issues within the process of launch. So we assessed the main issues, and we included the monitoring, the administration for different communities, and so on. We involved Christopher Burns, a professor from the University of Washington, who is experienced professional. With his help, we provided several trainings that got very successful feedback, and through survey, we found that the level of knowledge increased among the physicians providing PrEP. So we did a series of webinars for the target groups, and on the basis of the survey from US, we understood the recommendations for training programs that are oriented for physicians should include, first of all, increasing comfort or improving comfort when talking to clients, trying to eliminate the prejudice and disapproval, decreasing stigma, in particular patients from sexual minorities, and to take all together with the client the decision on PrEP and combine it with different other medical services, and to help the patients to realize that their health is in their hands, and to streamline the protocol of consultation with the client. So our intermediate results that we received through the period of October 2020 to April 2021, so 37 out of 39 priority facilities who provided the PrEP, out of them 46% got no previous experience on PrEP, and 796 patients took part in the PrEP program. Out of them, 424 patients were new in PrEP. So we got 52% that were referred to PrEP from other programs, and 94% of them came for the second time to proceed with PrEP. First, before we started our program, we started all the experience available. We tried to study and assess and to eliminate all the shortcomings or bottlenecks. We already have the experience how to work with health sites, so we received good outcomes, and we plan to do it for the future. We plan to increase the number of sites involved in PrEP program, implementing the model of building up the adherence, and to involve other physicians in this program, and the referral of the patients from the other programs to PrEP program, and to increase the accessibility of PrEP to our clients. Thank you very much for your attention, and I'm ready to answer your questions.
Пані Оксано, дуже дякую за
Oksana, thank you very much for your very interesting presentation, and we are very happy to get the support from your side. We know that that's let's say feedback from your side as doctors is very important, and our let's say cooperation and support, mutual support, it serves just for the advantage of our work. And as to the sites where you implemented PrEP, have you seen any problem with client or patients enrollment, in particular within COVID-19 lockdown, whether or not this condition impaired somehow the enrollment, because you know much better the sites, and maybe you have any kind of barriers from the sides of doctors or patients. And well, what is the average number of enrollment? Thank you very much for such a question. Yes, COVID-19 impaired our work as well as everyone's, and when we try to question about challenges, we question our doctors or workers, on-site workers, what are the challenges from them. They say, yes, with these waves of COVID-19, when the area or region is classified as red one, because of the morbidity increase in COVID-19, in particular when everyone stays home, scared of getting COVID-19 infection. So, plus our workers, all our workers, doctors in this case, all of them, notwithstanding their qualification, they are referred to COVID clinics, and they have to work over there because of the high prevalence of HIV, of COVID in the. So yes, this impacts our work. And so far, we don't have questions in chat. In case you have questions, again, please write your questions to chat, and we will answer your questions in the chat. For example, about the question that we have to involve also medical assistants or nurses into PrEP, in our project, we have lots of medical nurses working with PrEP dispense. Yes, we have a lot of nurses working with us. Yes. They're trained, they're qualified. And dear participants, I would like to introduce our next speaker, Nikolai Lunchenkov. He's a consultant doctor from ECOM, Eurasian Coalition on Health Rights, Gender and Sexual Diversity. He is involved for a long period, several years in the project, and also he works on a volunteer base, consulting people who live with HIV. And Nikolai, the floor is yours.
Hello everyone, and thank you so much for this amazing opportunity to give a presentation at your conference. Nowadays times getting strange, and I think this is one of the many conferences across the globe where all speakers present from their bedrooms. So welcome to my bedroom also. So today I will talk about PrEP in Eastern Europe and Central Asia, and we will go through the very short history of PrEP programs in Eastern Europe and Central Asia, what's the current situation with PrEP in our region. I will tell more about the project we are working on right now and the current status of it, and also I'd like to give one example on how several health services can be combined and integrated together to provide the best support and services to PrEP users in general. Before we move to the main presentation, I would like to give a couple of words about myself. So I'm a medical doctor specialized in infection disease and acute experience, both clinical and community. I used to work with UNAIDS, UNFPA, and other global leading organizations, and in this moment I'm serving as the LGBTQI+ health coordinator at ECOM. And my main research area is definitely PrEP, substance use among gay and bisexual men. This is like the main research interest. So let's move to the next slide about history of PrEP in our region. And for this, I have to say that PrEP came to Eastern Europe quite recently. The first project was established in 2017 in Georgia. Then the next one was, I think, the same year in 2017 in Moldova. Then we should definitely highlight 2018 when PrEP started to roll out in Ukraine, which is at this moment, and I'm pretty sure you all there about it, is the leading project in our region, and I think it's a great example on how you can roll out this prevention measure in Eastern European countries. So and now we have the following situation with other countries. We have 3, or you might say already 4, because recently Kazakhstan also started to provide PrEP. However, as far as I'm aware, the program on PrEP in Kazakhstan is quite recent. So, but it's already a good sign that we have countries, already 4 countries in our region providing PrEP. At this moment, 2 countries, Belarus and Kyrgyzstan, are planning to start their projects at this moment. And unfortunately, we have a huge uncertainty about the rest of the regional countries. And we still don't have PrEP in Russia, where we still, unfortunately, see resistance from Minister of Health and other official bodies against PrEP, but and more or less similar for other areas. But I hope that some of these countries will move forward to provide PrEP, and I personally have a big hope for Armenia to starting doing PrEP. And yeah, so however, if we have 4 projects working, the biggest and the main one is definitely Ukraine PrEP initiative. So I'm going to tell about our project, which we do in ECOM. It's called PrEP in Eastern and Central Asia project. So what we do, we provide technical support and assistance to projects which are already working or providing PrEP or about to start doing this. We support and facilitate exchange of experience and knowledge about PrEP in our region. We create and provide online trainings, and one of our plans is to do a regional consultation. Of course, with the whole COVID situation, we had to reschedule and to change the format, but it definitely on our table. And last but not least, one of the outcomes which we're about to finish at the end of the project is to present results of best practices in our region and share between organizations, so people simply can see what has been done in other countries, partner neighbor countries, to take some of these amazing initiatives and amazing ideas for their projects. Before we started to do this project, we did a needs assessment, and we tried to assess the knowledge of people working with PrEP and what challenges they face, what issues they face, what information they need, and definitely what we identified some of these countries facing relatively limited resources. Fortunately, due to limited financial resources, not all services, according to WHO, can be provided. We know about low awareness of the community about PrEP and its availability. Even though we have countries where you can get PrEP, not everybody knows that they can get it, in fact. Also, it should be worth to mention low awareness about different PrEP options, such as on demand, for example, and how to combine PrEP with other services. Therefore, based on these needs, we established several online trainings. I just put a couple of them to show you what basically we provided. It's like how how to start PrEP, how to support adherence, myths, and prejudices against PrEP, and how to deal with this. And to be honest, that gained a lot of support from people. Overall, we saw more like around 150 participants during our webinars. So it's a quite good number, especially if you know that basically these webinars targeting specifically people working in organizations. So we know and we see that people working in the area, they have motivation to learn and provide qualitative information. At this moment, what we're doing, we're planning to do a national consultation on PrEP in Kyrgyzstan, which will bring key stakeholders, and from Kyrgyzstan we expect several speakers from Kazakhstan to show their experience and what they already learned from doing their PrEP to support a sub-regional commitment to PrEP. We will do trainings to NGO workers on how to do PrEP, how to consult the people, how to work with clients, definitely how to use online settings, and so on and so forth. Also, for Armenia, we provided technical assistance with translation of comparative analysis of national and international guidelines on PrEP and PEP. So, and also I'm working in this moment, we do I do study on best practices in our region. So I hope that we will be able to share some results by the end of the summer, and I think it's quite exciting to see some great examples of what people do. However, even though unfortunately not everybody understands how you can use successfully PrEP to implement it with other health services. PrEP is actually a fantastic opportunity to bring people under health care observation for a long time, and offer not only testing for HIV or other STIs testing, but also to do chemsex support, which is definitely a growing issue in the region. Unspokenly, it's quite unspoken, unfortunately, but we know that it exists, and demand on specific services will be, if already, quite high. We definitely can use PrEP as a tool for hepatitis C, hepatitis B, or even hepatitis D microelimination, and we know that in our region, at least several countries, three countries are quite endemic for hepatitis D, which is definitely can be taken into account when providing PrEP programs. Nowadays, we can already discuss how we can use services to provide COVID-19 vaccination. As soon as we have people coming to our services, it would be a great option to do vaccination against COVID-19 as soon as possible. And also, we definitely can do the same vaccination for against other infections. I think everybody is aware about quite complicated and challenging situation with human rights in the region, and we also can do psychotrauma and building resilience services in PrEP programs. So now I go through the quick example on what is going on. For example, in Russia, this is the university clinic. H Clinic is the first private infectious disease clinic established 2017 by patients and doctors for creating the best HIV care. It's based in Moscow. Almost 12,000 patients visited in the 3 years, and for the last 2 years, H Clinic is a teaching center for medical university. On this clinic, so even though it's a private clinic, these folks establish PrEP. They are trying to definitely decrease prices for clients to make it more affordable and accessible for people. And what has amazed me a lot in this initiative, that it's a multidisciplinary approach, brings other services at the same point, not only vaccination and testing as we just discussed, but also some of these doctors participate in training program, which was a part of chemsex in Russia project organized by Terence Higgins Trust, which means that these clinicians can do chemsex support at the same time as they do PrEP. At the end, if you ask me what do we have at this moment, we definitely see the rise of initiatives in the region. However, these initiatives need technical support and maintenance, as well as regular training of healthcare providers and NGO workers. Fortunately, for example, in Russia, PrEP is available only via NGOs or private clinics, and there is no governmental program for that. PrEP services can be used for micro-elimination of viral hepatitis, and screening on viral hepatitis must be a part of screenings for those who want to start PrEP. Of course, PrEP programs is a unique opportunity to in combination with other sexual health services, including chemsex support. And thank you so much for your time, and I'll be happy to answer on your questions.
Пане Ніколай, надзвичайно дякую вам за дуже цікаву презентацію. Є дуже цікаві коментарі, і спробую їх сформулювати в запитання. Для наших надзвичайно цікавих лікарів тема, і вона для нас, для нашої країни загалом знаходиться така в сірій зоні або зоні абсолютно недослідженій. Це щодо хімсексу. Чи можете ви сказати про, можливо, маєте дані, про які саме ми говоримо, вживання яких саме ми говоримо найчастіше наркотиків? І хочу для учасників, для глядачів нагадати, що хімсекс – це поняття доволі нове, це вживання психоактивних речовин під час заняттям сексу для стимуляції відчуття і гостроти відчуття останнього. І дуже хотілося б почути про, якщо можете, які саме наркотики найбільш популярні в нашому регіоні, і як саме вони підвищують ризик інфікації. Дякую.
So, can you hear me now? Okay, perfect. I think the topic of chemsex is a pretty terra incognita in Eastern Europe, Central Asia, because we definitely have a lack of data, and we don't really know the prevalence of chemsex in the community, and specifically what, let's say, main factors for chemsex in our region. I know that just very few studies being conducted in Ukraine, and a very few, or even one organization-based study was conducted in Russia. Nevertheless, what we know from some reports published by UNODS is stimulants such as methadone are the main, probably the main drug for chemsex at least in Russia and in Ukraine, as far as again I'm aware. So in a very near future, we will publish a report of project Chemsex in Russia project, which we did together with Terence Higgins Trust. So we will provide some insights. So it was a qualitative study combined together with the developing of recommendations on how to provide Chemsex support in, let's say, Russian settings. But again, I think some of these recommendations can be used for other Eastern European countries, in Central Asian countries. So, and again, we don't really know the proper effects of chemsex on HIV among gay men, but I could assume that's definitely significant.
Thank you, Nikolai. I also have a question for you. I think you underscored the kind of the role of viral hepatitis screening for Hep B and Hep C. Within kind of PrEP programs, and especially for Eastern Europe. And maybe if you can speak to that a little bit more. WHO suggests annual Hep C screening for its implementation guidance annually for MSM. It's a suggestion in implementation guidance. And we also have Heather Marie here as well. So maybe she can make a comment from the Asia Pacific region, but really just kind of speak to a little bit more about viral hepatitis in the context of PrEP programs for some of these key populations. I think it's an important area to consider as well. Over to you. Thank you.
Yeah, that's definitely a key point in providing PrEP, that we need to screen people for viral hepatitis. But again, I would like to remind that some of Eastern European, Central Asian countries started national vaccination programs against hepatitis B less than 20 years ago. So we definitely must keep in mind when providing PrEP that screening on Hep B specifically is also very important, because, for for example, if we have, for example, PrEP users. Oh, can you hear me?
I can hear you.
Okay, but can't see me. Okay. Right. Yeah. And as I said, and in these countries where like national vaccinations against hepatitis B started less than 20 years ago, we need to screen people over 30 years. And again, as I said, for example, Kyrgyzstan is endemic country for hepatitis D, Delta agent, right? So how we approach this topic as well. And what I saw in different PrEP initiatives, that not always it's people providing consultation on vaccination options against hepatitis B and also treatment options for hep C. So I guess what we need to challenge all the time that screening and support services for viral hepatitis should be a keystone in this work.
Wonderful. Thank you for that. And I think I see Heather Marie actually typing in there. If we have over to Vitaly, any other questions for our presenter?
В чаті я не бачу, колеги, якщо наразі немає. І ми якраз пану Миколі дякуємо за презентацію. Я думаю, що дуже нам цікаво буде дізнатися потім фінальні результати дослідження щодо ролапу до контактної профілактики, можливо, дослідження, яких багато досліджень дуже проводить ЕКОМ, і ми тісно співпрацюємо, наші неурядові організації і добре знайомі з членами ЕКОМу, тому думаю, що ще раз дякуємо за участь. І зараз, колеги, Яніс?
Yes, I just want to comment just one quick thing, which I think Nikolai gave in his presentation. In the H clinic in Moscow, this private clinic, they're also doing something, because I visited Moscow for a conference pre-pandemic that you had kindly invited me to. Importantly, they actually take TDF alone with lamivudine separately, and people purchase that and use that as PrEP. So even though as WHO we're big on fixed dose combinations, in order to address the cost issue, because obviously tenofovir and emtricitabine in combination at $20 a month is more expensive than taking 2 separate pills for $7 a month, as you showed in your slide. I think this is just like a smart way around kind of thinking about cost reduction and getting people to get on PrEP. And so I think, and I've mentioned this in my sort of opening talk, WHO on its essential medicines list includes both TDF, FTC, TDF3TC, and TDF alone. But we usually, encourage countries to use the sort of combination of TDF, FTC, or TDF3TC. And that's also something that's happening in Latin America and also Asia and the Pacific. So that's all. And again, wonderful talk. Thank you so much.
Thank you.
Колеги, і зараз ми практично в час підійшли до однієї з найцікавіших панельних дискусій протягом наших 3 днів. Панельні дискусії, учасниками якої будуть наші представники ключових груп, лідери неурядових організацій, лідери активістського руху, які займаються програмами профілактики та програмами, націленими щодо протидії стигми та дискримінації. І хочу представити...
Discrimination. I would like to introduce our today's panelist, Андрій Чернишов, the activist who is involved in the advocacy against violations of rights of LGBT as well as MSM communities. Also, Adol Basenko will be with us, who is actively involved as a representative of Public Health Alliance, who is actively involved in prevention among the key audience, key population, which is injection drug users. Also, Natalia Isayeva, the activist who is working for quite many years in the programs focused on prophylaxis, reduction of prevention and reduction of stigma, also prevention of violation of rights, and she's fighting for the rights of women, commercial sex workers, generally sex workers. Colleagues, during the panel discussion, we shall try to hear from you the feedback. We shall ask you one question. This will be followed by the discussion in order to understand and hear our stakeholders who are all invited to participate as viewers in this panel discussion. You'll hear about the needs from the communities about implementation of pre-exposure prophylaxis. With that, I will request the colleagues to take us to the panel discussion. Thank you much. I believe that some of the participants are not in the office. So thank you for finding time for this. I have one question currently to all three. What are the ways that you can see towards creating demand for pre-exposure prophylaxis, involvement of clients for PrEP? How can we initiate involvement of more representatives of this key audience to the program of pre-exposure prophylaxis? Maybe advertising, or how else can involve more people from their key populations that require pre-exposure prophylaxis? Shall we go in the same order as on the screen? The first question is asked to Anton. Yeah, colleagues. In addition to my affiliation with Public Health Alliance, I'm a representative of injection drug users. It's an international network of people who inject drugs, and also National Council of Injection Drug Users. And in 2005, they have declared a position, common position of our community about application of PrEP. Of course, we had very few results of testing that PrEP really works against transmission of HIV through blood. Therefore, at that time, we had some doubt, including those related to the practical issues of implementation of such intervention, which are not known. Not absolutely. However, if you take the data of IVBS, there's a large number of people who use injection drugs, not really know what PrEP is about. Not speaking that they can be used. However, we know that this group is not prohibited. Those people generally have the access, and yet it's quite limited, actually, by the actual number of people who, from my community, receive that treatment. Therefore, today, it's the year 2021. Using this opportunity, I would like to congratulate you on the occasion of new political declaration passed the day before yesterday within the high-level meeting on HIV/AIDS on UN General Assembly. I will not go deeper into the reality, how it was approved, with some pressure of Russian Federation and so on. Yet it was approved. It's totally a progressive document compared to 2016. Also, as it mentions, not only the key communities, but also such things as harm reduction. Not just a harm reduction as a term. Also, one of the points, the list 9 intervention recommended by OSCE Unites for injection drug users. Therefore, a gradual expansion of PrEP to cover people who use injection drugs. One must have understanding that PrEP cannot replace any other prevention interventions, including, as Russia did before, when the main Dr. Onishchenko said, we have prohibition for methadone therapy. We have our own way. All the injection drug users will have a PrEP. Everybody will rescue, that will be rescued, and we shall win over HIV. It's not, cannot be allowed in the Ukrainian reality. We, as a community, we support as the expansion, yet under the conditions with specific critical things. Without them, expansion such things and generally proposing it for our community will not be efficient. First of all, there is harm reduction program, including the basic package, which went for government financing already. So PrEP must be considered as part of the comprehensive response, not just a standalone intervention, which mono or solo intervention as it proposed instead of something else. That's first. The second thing is that we know that yet we have problems with access to ART as such for injection drug users. Once again, as I say, it must be in line with any expansion of PrEP for injection drug users. Of course, this is about those who are not infected so far. The medical system is all the same. The non-government organization cooperated with, and we don't have any other system. It must be, inter alia, this must take into account the work for access for those from our community who are positive and already require ART. The third thing is that obviously it must be the free, available, affordable, with signed informed consent and with no forced intervention, which is must be voluntary, with no not forcible one. I reiterate that from the perspective of Ukrainian community about PrEP, in order to expand it to cover injection drug users, that for 6 years we have received the new data which say that it's possible and also important to have PrEP, to propose PrEP also people who use drugs. Also understand that. And the last thing I would like to say, there was a question, what must be done to have it more attractive or affordable with any
в свій час запускали як нову і пропонували людям, які
intervention that we admitted as new and proposed to injection drug users, users of drugs or users of injection drugs. I would like to expand that context to people who are using injection drugs. We believe that the drug scene is changing. The sexual way is for people who use non-injection drugs like psychoactive substances. Ukraine is overwhelmed with the question of sex, as my colleague Chernyshevsky has discussed. So we speak of the people who use drugs anyway. As any new intervention, anything starts with accessible, simple, understandable information from for the community, what it is, why is that important, is this not motivate people, and then infrastructure things can be connected, related to availability, convenience, not affordability of availability, whether you buy it or whether you don't, whether it's somewhere on the house or whether it's not. Understand I press for time? So it must be available on every level. Whenever reform goes, whenever changes of approaches go for, of how we work with the clients, whether it's a medical institution or the NGO, availability and simplicity must be in place. Also, I would like to express my support, and I'm ready to support further development and expansion of programs of PrEP, maybe it's not the top priority, and yet it can be one of the comprehensive package, quite an important of that package of integrated services. Thank you, Anton. And thank you very much for nice comments. We have recorded that, indeed. We are pressed for time. Yanis, you have your hand raised. Do you have a short comment or question?
Yes, just a short comment. Thank you, Anton, for really that really wonderful perspective around PrEP and for people who inject drugs. I just want to kind of make note of what Don Smith said from day one as well, and the experience in the US, and how they're thinking about offering PrEP to people who are injecting drugs, and thinking about obviously real sort of an extra layer of protection. I think is really important, and I think Heather Marie also made a point in that on an additional prevention choice. I think the other thing, just to make note, is what Keith in his talk earlier today mentioned, which is also thinking about the sexual network partners of people who inject, and so their ability to access PrEP and get on PrEP as well. And I think that's just an important point to emphasize. So thank you. Over to you, and really appreciate your comments, Anton.
Колеги, переходимо до наступного, до Андрію. Вам слово.
Shall we move to the next participant? Andrei, you have the floor. I would like to hear from you. What is your vision about involvement, initiation of pre-exposure prophylaxis for MSM? We have heard quite a lot of information about the obstacles. What is your opinion? What is your vision about involvement of MSM, the key population which uses PrEP most of all? Good afternoon. I would like to make several comments about improvement of access to pre-exposure prophylaxis for MSM and generally LGBT community. Today, there are no representatives of transgender people. I would like to draw the attention for today. We have discussed quite a lot that for improvement of access to pre-exposure prophylaxis, because this is about not only MSM, but generally all of the target populations, key populations. This is expansion of the number of sites where PrEP can be received by representatives of the key population. Of course, the highest need, I would like to reiterate this once again, is receiving of PrEP as well as diagnostics, necessary diagnostics, in the so-called safe spaces, in those territories where community representatives would feel themselves convenient, also safe, and where they can have maximum trust to the employees who work there, because it's really as the client is. That's the first thing. And of course, the best will be when those places and access points is a larger number. Because quite many NGOs are ready to join, and yet we observe actually monopolization of services, and it's possible to receive pre-exposure prophylaxis only in the age centers, public health centers, actually in also other institutions or the NGOs, it's not possible. Unless we overcome that barrier, we cannot substantially improve access. We need also medical institutions, private clinics. There is probably more trust compared to the government institutions. For more general population, those can be drugstores as well as NGOs. The next aspect, a very important aspect, which is not really discussed, which is also a big problem, is providing of services of pre-exposure prophylaxis in conjunction with other services, this so-called combination prevention, when services are provided for HIV testing comprehensively. Let's assume that a service is provided for pre-exposure prophylaxis. You know that those clients are very vulnerable, in particular to STIs or viral hepatitis, B and C. And we have a problem when we would like to have a client on PrEP. We can detect hepatitis or at least syphilis. And generally in Ukraine, practically, we don't have social support or case management of such cases. Like viral hepatitis or STI, the clients are just cross-referred to the institutions like dispensaries, if it is chlamydiosis, syphilis, or gonorrhea, and regretfully, that dermatology venerology service, by my observations of my colleagues, it operates like on another planet. It's totally separated from the medical service. It lives its own life, and it simply uses are very homophobos, they are drug phobos and trans phobos. And as far as I know, people still work, the old doctors work from the former Soviet Union. If there is syphilis in a person, secondary syphilis, as I have it from my own experience, you must be placed into hospital for 1 month. And this never happens, probably in civilized countries. And in our country, yes, they do place in the hospital. And also those clients, I speak of MSM, they receive suppression, homophobos, transphobos statements. And of course, after that, our clients don't really want to visit medical institutions, or they even refuse from their pre-exposure prophylaxis because they have psychological trauma related to that. So they have psychological barriers. A psychologist, psychoanalyst, or psychiatrist, regretfully, this is not discussed. And yet, I would like to raise this important topic. Unless we have a comprehensive package of such services, we also cannot substantially improve access to pre-exposure prophylaxis and generally to receiving services of the key groups. This is not only about pre-exposure prophylaxis. And also, I would like to mention that we need to do, as I said before, more than once, and this is still ignored, we need the right geographical focus or distribution for pre-exposure prophylaxis, take into account the specificity of every target group. Let's presume, I will speak now of MSM, due to the migration processes, and especially during COVID-19, in smaller or medium cities, there is a big outflow of MSM, and generally representatives of LGBT, they migrate into big cities or abroad, into the countries of Western and Central Europe. And we need to distribute our funds, the donor funds, in the right way, having into account those factors. And of course,
робити все ж таки доступ до контактної профілактики, враховуючи специфіку важкодоступних.
And we need to provide for the access to PrEP, and specifically for key groups or communities, as we already mentioned, for chemsex communities or some specific groups, which could be quite closed ones. And we, for example, we already started to work with chemsex groups. We started a pilot project in Kiev, and they're very vulnerable to STIs, to HIV. So we started a number of them, and the demand and so on. And yet, we have to keep in mind that there are other closed specific groups, hardly accessible, like sometimes people aged 45 plus, or cross groups like sex workers, so-called skin lovers. They have also, well, we have to find access to them, I would like to say that. And yet we have to raise up acknowledgement, in particular among MSM and other groups. We already deployed work with MSM community like Hornet and so on, lots of promotions for MSMs on PrEP, but still we have to work with the acknowledgement with other groups and to deliver the information on the aim of PrEP, and also to work with the broader social, let's say, society, broader society, because the society itself as a whole should know what PrEP is. And yes, hard part of work is to motivate people to PrEP. Yes, thank you very much. But this it's a time issue, because we have to keep in mind the timing is in for. Also, I took notes of your all your talks. And Natalia, do you hear us? The floor is yours. How to involve sex workers, women sex workers, or female sex workers to PrEP programs. Good afternoon. Thank you for the invitation, first of all. And I support everything that Anton already said. And yes, first of all, we started when we, at the very beginning of the project, we started consultation with all our colleagues in future providers, and namely when we started to work with male sex workers, female sex workers, transgender people, sex workers, and yes, I agree with Anton that this project should not, let's say, substitute the other preventative projects or methods, because, for example, we have when we have only, for example, 200 condoms per one client, for prophylaxis, this is really not enough. Or like in other countries, people think that if they take this pill will protect them from everything. STIs and HIV and everything. So we should also inform people that this pill protects only from HIV, and it's not like some magic pill that protects from everything. And also, yes, we should work with legislation to incorporate the amendments to legislation, namely, for example, when, for example, a woman who earlier was involved in the prostitution, and she stays on PrEP, and when a police, let's say, arresting her, finds a PrEP pill in her bag, so this may be, for example, as a negative sign that she's a sex worker, and so they can incriminate her in with the sex work or sex working activities and so on. So, and we should keep in mind everything, and we should implement complex advocacy and also changing legislation, changing the attitude of the broader society towards PrEP, and telling about what could be methods of intervention. So I'm just, I left I was left really very, very little time to present. I tried to talk about everything in a minute. Yanis, a short comment from you, because we're already on the eve of
Thank you so much.
break.
Great. And I just really want to thank all the panelists, and a specific question to Natalia regarding Ezra showed some really nice data on awareness of PrEP in people who inject drugs. Do we have any similar data that we have either at the national level or for some specific oblasts as far as the level of PrEP awareness in sex workers, specifically female sex workers? And then I also just noted, I put something in the chat to everybody. I think we also, the last presentation today will be about next generation products for PrEP, including long-acting cabotegravir. And thinking on that point that you mentioned, that sex workers, female sex workers are conscious and nervous about being identified as PrEP users when a client could, see a pill. We also need to consider the role of long-acting cabotegravir as having that benefit for these women. So I think that's sort of like two separate issues that I asked there. What is the level of awareness in female sex workers? And then also that point on cabotegravir as a potential option for this population. So thank you, Natalia. Over to you.
Якщо це до мене питання, то прошу.
If this is a question to me, so I don't know how to use translation, and I.
Є обізнаність про ДКП серед секс-працівниць чи працівників загалом?
Така початкова є в деяких регіонах вже починають.
In particular to the awareness, yes. We work on them on the raising of awareness, but still we need more efforts to deploy, because first of all, problem with barrier contraception. It's question of costs in financing, but this is not the main item. First of all, we put emphasis on PrEP. Yes, to raise awareness, to raise the demands, and yes, we heard that PrEP is not as a substitution of other methods of prophylaxis. It should be provided in complex with other preventative services, and not to be a substitute. Yes, that's first of all. And thank you for your time. I wish you safe drive to those who are driving, and see you all next time. And now we declare a break. 7 minutes break till 3:40 p.m. Please stay in Zoom. Don't exit the conference. Stay with us. 7 minutes break. Yes, I wish you nice coffee. And also, you should add about the role of non-governmental organization. Yes, the implementation, PrEP implementation is not possible without NGOs. Yes, NGOs should stay in focus of the intervention. Yes, PrEP is, let's say, community-based. Yes, that's why NGOs are in great role in that. And so
У мене буде моє маленьке кохання.
У мене будуть нові досягнення, тому що мрії здійснюються. За умови ефективного лікування ВІЛ не передається.
Це найромантичніше побачення. З тобою цінуєш кожну мить. Бо за умови ефективного лікування ВІЛ не передається.
Так круто відчувати усі барви повноцінного життя. Кохати, народжувати, мріяти. Бо за умови ефективного лікування ВІЛ не передається.
Понад 100 тисяч ВІЛ-інфікованих українців уже приймають АРВ-терапію. Лікування безкоштовне та конфіденційне.
У разі досягнення невизначального вірусного навантаження ВІЛ не передається.
Головне – не переривати лікування.
Зроби лише один крок. Не дай ВІЛ зруйнувати твоє повноцінне життя.
Сьогодні він з нею, завтра з ним, післязавтра з ними. Макс не обмежує свої бажання, але розуміє, що ніколи не може бути впевненим у випадкових партнерах. Тому Макс обирає доконтактну профілактику PrEP. PrEP – це таблетки, які не дають вірусу інфікувати організм. Їх приймають щоденно або ситуаційно до та після статевого контакту. Всесвітня організація охорони здоров'я рекомендує PrEP людям, які практикують незахищений секс, мають кілька сексуальних партнерів або партнера, який живе з ВІЛ. Завдяки PrEP Максим залишається здоровим та має свободу вибору. Він думає про себе, про нього та про неї. Подумай і ти. Обери безпечне життя зі свободою вибору. Захисти себе та інших. Зателефонуй на гарячу лінію з питань ВІЛ-СНІДу та завітай на сторінку Центру громадського здоров'я.
У мене буде моє маленьке кохання.
У мене будуть нові досягнення, тому що мрії здійснюються. За умови ефективного лікування ВІЛ не передається.
Це найромантичніше побачення. З тобою цінуєш кожну мить. Бо за умови ефективного лікування ВІЛ не передається.
Так круто відчувати усі барви повноцінного життя. Кохати, народжувати, мріяти. Бо за умови ефективного лікування ВІЛ не передається.
Понад 100 тисяч ВІЛ-інфікованих українців уже приймають АРВ-терапію. Лікування безкоштовне та конфіденційне.
У разі досягнення невизначального вірусного навантаження ВІЛ не передається.
Головне – не переривати лікування.
Зроби лише один крок. Не дай ВІЛ зруйнувати твоє повноцінне життя.
Сьогодні він з нею, завтра з ним, післязавтра з ними. Макс не обмежує свої бажання, але розуміє, що ніколи не може бути впевненим у випадкових партнерах. Тому Макс обирає доконтактну профілактику PrEP. PrEP – це таблетки, які не дають вірусу інфікувати організм. Їх приймають щоденно або ситуаційно до та після статевого контакту. Всесвітня організація охорони здоров'я рекомендує PrEP людям, які практикують незахищений секс, мають кілька сексуальних партнерів або партнера, який живе з ВІЛ. Завдяки PrEP Максим залишається здоровим та має свободу вибору. Він думає про себе, про нього та про неї. Подумай і ти. Обери безпечне життя зі свободою вибору. Захисти себе та інших. Зателефонуй на гарячу лінію з питань ВІЛ-СНІДу та завітай на сторінку Центру громадського здоров'я.
Great. Welcome back, everybody.
Я сподіваюся, всі повернулися, встигли хоча б заварити каву. Була дуже коротка перерва, але ми пробуємо бути в графіку, і зараз у нас дуже цікаві після перерви презентації. Янісе, вам слово.
Apologies, I think the translation is not working.
1, 2, 3, can you read me? Can you read me?
Yes, I can. Thank you very much. Great. So we're back. Great. We are here for our final session of the day. I hope everybody has had that quick coffee break and we're ready to go. I'm in the final session today. We have 3 great talks coming up, and I'm super delighted to have our WHO colleague from the regional office in Copenhagen, Dr. Antons Mozalewskis. He's a medical officer in our Copenhagen office and also the regional focal point for viral hepatitis and PrEP. We've engaged in work with Antons for many years now on ensuring that countries in the WHO Euro region not only adopt PrEP as a policy, but really think about implementing PrEP and ensuring meaningful coverage, and also to the point that Heather Marie earlier mentioned, was to ensure that rapid scale-up can actually have a rapid decline in new HIV infections. So today, Antons is tasked with presenting about STIs and viral hepatitis in the context of oral PrEP and also in the WHO region. So it is over to you, Antons, and really delighted to have you present and be with us. Thank you.
Thank you very much, Yanis, and nice to see everyone. I have a difficult task to present a lot of stuff in a very short time, so I will briefly tell you about the global and the regional STI epidemiology, about STI in the context of PrEP, a little bit about the WHO STI guidelines, and in the end also a little bit about viral hepatitis in the context of STI. So first of all, when we talk about STI, we have to remember that most of STI are silent and asymptomatic. So usually it's not perceived as a as a really something dangerous, as for example HIV or other infectious diseases. But still, if we look at the data which has been reporting and modeled globally, it's a really huge public health issue. And the latest WHO report estimated that in 2020 there were almost 400 million new curable STI infections. The curable STI infections, we mean syphilis, gonorrhea, chlamydia, and also trichomoniasis. And when we look more closely, then there are definitely some very negative impacts on health from STI. So STI compromise quality of life, and especially sexual life. They cause infertility, and they can cause also some neonatal problems. And also they curable STIs, especially HSV and other, they can increase risk of HIV acquisition. And when we talk about mortality due to STI, it's estimated that there are around 200,000 deaths from congenital syphilis, and there is more than 300,000 deaths due to cervical cancer, which are due to HPV or human papillomavirus, which is another viral STIs, which also has a considerable burden of not only cervical cancer, but also anorectal cancer and pharyngeal cancer, especially among MSM. So, but good news that the WHO and the member states of WHO have recognized the public health threat of the STIs, and the first global strategy on STI was adopted in 2016, also calling for ending STI epidemic by 2030. And there are three priority areas: gonorrhea, syphilis, and HPV. And there are a number of targets. I'm not going to read them all, but you can see they are mostly referred to the reduction of incidence in syphilis, gonorrhea, and our STIs. So just to say also briefly, what is the overall impact of effectively addressing the STIs? It's first of all, it's combating antimicrobial resistance. It's eliminating adverse neonatal effects. As I mentioned, congenital syphilis, first of all, it helps to reduce the HIV transmission and prevent cancer, especially cervical cancer, but also other cancer types which are caused by human papillomavirus. It helps to decrease the burden on infertility, and also, if taking as a comprehensive part of the sexual health, it supports health of young people. So taking this into account, you know, there was a new WHO report published just a couple of weeks ago on HIV, hepatitis, and STIs, and we could see that HIV infections are falling globally in most of the regions. Even though we are still below the global target. And also viral hepatitis infections, there is some progress in treatment, and also due to hepatitis B vaccination, we see also dramatic decrease in incidence. But if we look at the situation with STIs, then other than slow declines in congenital syphilis, the incidence of most other STIs is still on the plateau or even increasing. If we look at the EU data, because that's where we have the relatively better surveillance for STIs, we can see that in last 10 years, the incidence or rates of syphilis infections is increasing, specifically in men. And if we look at the transmission mode, that we see that this increase is specifically marked, and actually it's because of the transmission among MSM. And there are some possible factors identified through the literature review which contributes to this increase of rates of syphilis in EU countries. That includes condomless sex, the effect of HIV treatment, maybe the increased number of sex partners, and also different practices in finding partners, like social networking or mobile dating applications, let's say. If we look at the reported number of gonorrhea cases, this picture is pretty similar, and there is an increase particularly marked among MSM in the EU countries. So if we look at the response to STI in Europe, there was a survey conducted 2 years ago, and although the response rate was just around 50%, we can say that from this survey, we see that around 1/3 of member states have a national STI strategic plan. A little bit better situation with the national guidelines for STI treatment and diagnosis, so around 70%. But the antimicrobial surveillance is more or less well established for gonococcal infections, but also again we need to stress that this is mostly right for the EU countries. So the gaps is, of course, the limited availability and quality data on STI from EU, but also especially from non-EU countries. Yeah, we know that some data is reported to GAM or to the Dublin Monitoring Declaration, but this data is really bad, and we cannot really make any reliable conclusions based on this data. If we look at what the data that we have, we see that the young heterosexuals, and mostly in EUAA, are affected by new chlamydia and gonorrhea infections. If we look at MSM, that there is an increase in gonorrhea and syphilis cases. And what is new, that there is a new increasing syphilis and gonococcal trends also in HIV negative MSM, which also is already for quite a number of years. And lack of screening programs for chlamydia in young people in many countries. And also we know that the key populations are particularly prone to stigma and discrimination, and there is lack of funding for key population interventions in the Eastern European and Central Asian countries, especially where global funding is going down. So there were a lot of concerns about the effect of PrEP on incidence of bacterial STI, and here we will try to see what really is the picture. So as you can see, this is the visualization of the increase of global PrEP uptake from 2012, when the Truvada was first approved by the FDA, and 2015, where WHO recommended PrEP for any person at risk. So there is a substantial increase in scale up of PrEP use in the last 2 or 3 years. But if we look at the incidence of HIV infections and other STIs, that we can see that quite sharp increase in incidence of gonorrhea and early syphilis started already much before PrEP became available. So you can see that probably there are different reasons for increase of STIs, and that's why also we are stressing every time that PrEP is an opportunity. It's not a risk. So also one of the reasons is that the men who are taking PrEP, they are more often tested for STIs, and that's why they're earlier diagnosed. This is data from the ECDC Hornet surveys in 2017. You can see that the rate of testing for STI was higher taking PrEP. And this is quite old data from 2017, but still it's quite clear tendency. So just to summarize on the issue of PrEP and STIs, so when implementing PrEP, countries should plan for regular testing for STIs. It's recommended by WHO, definitely, and it's really an opportunity which should not be missed. So PrEP is an opportunity to enhance screening and prevention, and save costs, and also make the program sustainable. This is also an opportunity to show the commitment to people-centered approach. And also, it's also an opportunity to reach communities for those who are at risk of both HIV and STI. So PrEP should be implemented as part of combination HIV prevention. That includes also testing for STIs. So talking about some innovations, just a quick slide that especially for STI diagnostic, there is a new opportunities for point of care testing for bacterial STIs, although they remain quite limited to countries with rich resources, because these tests are relatively they're quite expensive, but where in settings that can be implemented, that shows that it really improves the capacity for screening for asymptomatic STIs. So just a few words about the WHO STI treatment guidelines, and they were developed and published last in 2016 and 2017, and they just the key messages are coming that for chlamydia infection, important options are azithromycin and doxycycline. For a treatment of gonorrhea, especially where antimicrobial resistant surveillance is not in place, dual therapy with ceftriaxone and azithromycin is preferred. And there are some also options for treatment of herpes virus infections. Just in a few words about chlamydia and LGV, as you know, there are two main regimens, so is azithromycin and doxycycline. And it also important to stress that for anorectal infection, doxycycline is preferred over azithromycin. If we talk about gonococcal infection, I already mentioned that in settings where there is not very strong antimicrobial resistance surveillance in place, dual therapy with ceftriaxone and azithromycin is recommended as a preferable regimen. And finally, talking about syphilis treatment, there is a very strong recommendation for long-acting benzathine penicillin G as a single injection for early syphilis. That's a preferred option over any other option. There are also options for pregnant women. I'm not going to go through all the regimens, but the main message is that long-acting injection, like single injection, is the recommended treatment regimen for early syphilis for all people, except those who have allergic reactions to penicillin. So the problem with this is that benzathine penicillin it's considered to be an old drug, and the market, apart from treatment of syphilis, is not so large. So we need to take into account that there are some risks of shortages that need to be avoided, especially when we look at the necessity to treat pregnant women from syphilis to prevent congenital syphilis. So again, to summarize, the PrEP services are the opportunity for STI prevention and control. And you can find this technical brief online, which was published just 2 years ago, and provides all the consideration about the tests that need to be conducted before starting PrEP and during PrEP. And I'm sure you're all aware of those tests, but we just need to make sure that it's really implemented in the PrEP programs. And the key points about the STIs that they, after years of neglect, now finally and globally we see attention is being paid, partly because of the increasing incidence of STIs, but also because there are new opportunities to address when we integrate STI care into PrEP and HIV services. There is high burden, and we see it from the global report. And also we need to place greater focus on STIs in a context of expanding use of PrEP. So we have to really address STIs and the population that at risk, that they have a comprehensive STI prevention and care in one place, and also in a client-friendly way. So finally, just to end my presentation, I'm going to say just in 2 slides or 3 slides about the viral hepatitis services, which must be an integrated part of comprehensive PrEP services. So because HIV, HBV, and HCV share some transmission routes. There are some common prevention interventions, and also the comprehensive HIV PrEP programs can offer and have to offer HBV testing, which will be followed by vaccination or linkage to care. And in case of HCV treatment, in case of positive HCV treatment, linkage to care and treatment. Also, HIV PrEP drugs are also effective in treatment of HBV, and also HBV treatment may act as HIV PrEP. So if the person is infected for HBV, this can be taken into account when he has also increased risk for HIV. The clinicians have to take this into account and prescribe the medicines which will act also as PrEP. Regarding HCV virus, for long years, we had only evidence of increased incidence among HIV positive MSM, but now there is new evidence is coming that also HIV negative MSM, especially those who are taking PrEP, are also at increased risk for HCV infection. And as you know, also, it was already mentioned today that HCV screening is recommended at least once a year. And it can be also, the HIV express tests can be used in the settings, or even HIV self-tests. WHO is coming up with a recommendation for HCV test later this year. And I think especially in the PrEP context, it can be a very reasonable option for regular screening for HCV for those who are at risk. A couple of words about the potential drug-to-drug interaction. The new HCV medicines are quite safe, and they don't interact with the medicines which are used for PrEP. So if you are using PrEP and if you have to be treated for HCV, usually there is no need to stop PrEP. And for HBV, an important moment is that for people infected with HBV virus, event-driven PrEP is not suitable because of the possible reactivation of chronic HBV infection. And this is the summary slide again, that PrEP services, they can serve both as both different services for HIV, partner testing, and STI services. They can serve as referral to PrEP services, and inter-PrEP services can serve as a gateway to all other related services. So they can be like a hub of the people-centered services for STIs, HIV prevention, family planning, and so on and so on. So thank you for your attention. And I see there's a lot of questions already in the chat.
Great. Antons, thank you so much. I'll just 1 second, Vitaly. There's a number of questions in Ukrainian there. I just asked a quick question. Maybe you can answer it about kind of leveraging the gene expert machines that are already in countries for TB, TB programs. But I think also welcome you to also have some thoughts on the syphilis treatment currently as it is in Ukraine. We've discussed this, and I think probably some of those questions are speaking to that. So over to you, Antons and Vitaly, for you to facilitate the discussion.
I see from the chat there are many remarks about the STI treatment in Ukraine, especially syphilis treatment in Ukraine. I don't know if it's for answer this question, because I think the next presentation will be about Ukraine. Vitaly?
Дякую. Так, тут більшість коментарів у нас.
Yes, thanks. The majority of comments is the majority of these are comments, but there is a question whether or not in Ukraine syphilis treatment is possible only in hospitals. I mean, in inpatient condition, and whether or not those who stay on syphilis treatment should they proceed with PrEP intake or not. And there's, yes, and the clinical syphilis treatment may be a barrier to PrEP or adherence to PrEP. Do you think it can be a barrier or not? I mean, when the people stay in inpatient department for syphilis treatment.
Thank you for the question, and I'm not sure if I can answer this question because for us it's not very clear what is the justification for placing people for treatment. We know that probably it's because of the injectable treatment, but this is really an outdated treatment approach, and yeah, we would like to hear from the colleagues which are aware. Is there a specific reason why the STI and especially syphilis treatment guidelines have not been updated in Ukraine? So is the problem with the registration of the benzathine penicillin, or is it the problem with the stock outs, or this is really a good question, and we would really like to know and how we can support changing this situation towards better.
Дякую. Я думаю, що зараз дійсно відповідь ми частково зможемо отримати.
Thank you very much. I think the subsequent presentation will maybe bring some answers to those questions, or will shed light to syphilis treatment in Ukraine, namely. So I would like to give the floor to Lyudmila Derevyanko, who is a PhD in medicine, associate professor, private higher educational establishment, Kyiv Medical University, and president of international NGO Dermatology for Children in Sexually Transmitted Infections. Lyudmila, the floor is yours. Good morning, dear colleagues. I'm very happy to be here on the conference Pre-Exposure Prophylaxis, HIV, and to provide the information on sexually transmitted infections in Ukraine, to talk about trends and challenges. And we cannot overestimate the sexually transmitted infections, since they are one of the components of the public health care that have the impact on reproductive health, as well health of the children, and the role of mediators between the sexually transmitted infections and HIV. So they have also impact through their role in promotion sexual infection and HIV on the national individual economy. What is the situation in Ukraine? The official statistics evidences that the main diseases that are registered, I mean, the STIs, these are the syphilis, gonorrhea, chlamydial infection, urogenital mycoplasmosis, and trichomoniasis, they keep the tendency to decrease. So, in their gender distribution says that among male population, this morbidity is 3 times higher than in women. And the statistics data from European Union. So on this basis, we can say that our national statistics does not present the real situation. Such sexually transmitted disease as syphilis that leads to the impairment of many organs and systems, and also speeds up the HIV infection, has a tendency to increase, namely in the area of so-called hidden syphilis state. That evidences that we really miss the prophylaxis in Ukraine. And at the same time, many years ago, we were recommended to develop national strategy due to the HIV epidemic. Unfortunately, Ukraine didn't adopt this strategy, but the global strategy says that the syphilis is one of the priority among the activities that need the urgent response, in particular to eliminate the inborn syphilis and to control the syphilis spread in the key population. That goes in line with the problematics of our population. The presence of syphilis increases the risks threefold among the population, and plus at women, this also can act as an infection that is transferred from mother to child. So we have to include this in our priorities in order to control HIV and to fight this epidemic that has a trend to increase in Ukraine, unfortunately. Ministry of Health of Ukraine took decision on elimination of inborn syphilis, and with that, the normative documents were updated, reviewed, and we also decided to participate in WHO mission that in a whole speed up the syphilis combating among women and also key population and risk groups. So these risk groups, through their contacts, they serve as a bridge to infect further women and increasing the birth of children with inborns. So the analysis of legislative basis shows that it is really outdated since up to recommendation of CDC. We implemented some regulations, but unfortunately they don't include the definition from Orange Book for elimination of syphilis in epidemic monitoring, and the main recommendation would be reviewing the normative base, namely the standards of treating women with the benzimethylpenicillin and using the up-to-date tests systems instead of the outdated tests like Wassermann and precipitation tests, and also for Ukrainian laboratories to participate in serological diagnostics of syphilis, and also to connect to international network, and also to implement the systemic monitoring and assessment as in HIV, and so to integrate the interdisciplinary management of STIs, of the target groups, and the interagency commission was created to develop the new recommendations to combat syphilis. And the draft of this recommendation says that the persons who stay on pre-exposure prophylaxis should pass one of the treponemin tests, then immune blotting, ELISA tests, rapid tests or express tests, and in case of positive results for treponema, they should go through additional testing on non-treponema testing. And the group of experts has adopted the specific algorithm for testing persons staying on PrEP. What else? That we include in the recommendation, namely these are the express tests to diagnose syphilis, and for the distant laboratories through the Global Fund financing, these express tests will be purchased for syphilis diagnostics and as well as the combined diagnostics of HIV and syphilis altogether. Concerning the syphilis treatment in Ukraine, we have several barriers since the international guidelines for infectious syphilis recommend benzylpenicillin 2.5 international units, 1 to 3 injections, in particular in the hidden cases, but in the absence of prolonged benzantine, treatment is carried out in hospitals with multiple injections of short-acting penicillin after 4 hours, from 14 to 28 days, depending on the form of syphilis. And this is really far from the international standards. I would say this is kind of Soviet standards. So such guidelines should be reviewed and updated to the up-to-date level. And unfortunately, we experience shortages of benzantine penicillin, and our group of experts also try to persuade the Ministry of Health to register this drug in order to treat the target populations and also women, pregnant women or women that plan to be pregnant. And I would like to use my opportunity to speak out to our colleagues, and namely those who know that this product is sold in pharmacies, but not by prescriptions. So, and it's still here a hidden problem. So we have to make efforts in order to register this drug quickly. In most common STIs like trichomoniasis, genital mycoplasmosis, and chlamydia are mostly registered in female populations, and syphilis and gonorrhea among men. And STI in Ukraine have acquired the status of socially significant diseases, but because it is a hidden problem, so still we need strategy with goals and targets, as we did for HIV, tuberculosis, and hepatitis, and in particular implementation of international guidelines for STI with modern methods of diagnostics and treatment of mostly single-dose drugs in an outpatient setting would be really active and effective prophylaxis to stop HIV spreading. So we need to integrate the management of public in social organizations into the related medical services, and to reach the good standards. Thank you very much for your assistance. This is me with my groups of students. They are really agents of changes, and thank you very much for your attention.
Great. Thank you very much, Ludmila, for that comprehensive talk. We are going to translate those slides into English, so I'm able to look at the data more carefully. Obviously, kind of what I took from your talk is obviously the need to move Ukraine's sort of guidelines and STI care into sort of international guidance and sort of improve the quality of screening and treatment. My colleague Anton's we sort of raised the issue on the treatment of syphilis, which you kind of spoke to. My question to you on that, specifically around syphilis, is really on pragmatic terms, how to actually move forward with not keeping people in the hospital for 14 to 28 days for syphilis treatment. That's my first sort of question. And just secondly, a comment, and maybe for you to reflect on, I understand there's a huge budget impact, but in doing all this other asymptomatic screening for STIs as part of a PrEP program, and WHO does make suggestions for this additional care. And we do see this divide in terms of what a PrEP program in London can offer, or Glasgow, and what a PrEP program can offer in Eastern Europe. And this goes for other countries as well. But my thinking is that we should still make some effort in ensuring that there is, a little bit more investment and focus on additional STI services for the PrEP users versus others, because PrEP users in themselves are at an elevated risk for not just HIV, but the other STIs. So we need maybe a little bit more thinking as to how to make that happen, even when funding is not there and there may not be motivation from governments to invest in STIs further. So that's all I have to say. Over to you, and I really appreciate your talk. Thank you. I can't hear anything.
Mm-hmm. So far, no one is talking.
1 second. Oh.
No one yet is talking, I see.
Sorry, may I ask the question? Yeah.
Please do, Anton.
Sorry?
Будь ласка, Антоне.
Yeah. So I think that we couldn't really understand from what we heard this day. So is there an issue also with the registration and availability of the long-acting penicillin formulations, or is it just a question of the guidelines which are currently being updated?
Вас не чути, пані Людмила? Мікрофон. О, зараз.
Доброго дня ще раз.
Good afternoon once more. Well, concerning penicillin, it's totally absent in Ukraine for many years. Its registration, certification in Ukraine has expired, but it was not renewed. We addressed several times to MOH for us to re-register this drug in Ukraine, because we need it to treat, for example, pregnant women. And unfortunately, there were no response. We've got already some amount of long-term penicillin. We got them, but so far I heard that there is a stock out also in Germany, that it is absent in Germany and other countries. So far, I heard that it is absent in UK, and this product is not registered in UK, but still doctors have the right to prescribe it, even out of label. Notwithstanding, for the patients to give a prescription, and the person could go to any pharmacy and buy it. It's just $10 per one injection, what we have now. It's cost in Ukraine. And I also talked to Clinton funds in Ukraine, and I was told that, yes, there are companies that are willing to enter Ukrainian market, but there's no link, there's no contact with agencies in Ukraine, national agencies in Ukraine. And this penicillin is the first group drug. So, and since we don't have this long-term or prolonged term penicillin, so our doctors have to say to send persons to send patients to clinics and to make like 4 times a day injections. That's this. We would really eager to have this prolonged penicillin as the first therapy.
Наскільки легко лікар по протоколу може використовувати пролонговані
Protocol. As a doctor use the prolonged penicillin. If the patient goes to the government sector for syphilis treatment free of charge, according to the protocol, is it really possible to administer prolonged drugs, or the first line will be the advantage? Just basic unprolonged short-term penicillin, because it is absent. Therefore, they are referred to hospitalization, those hospital beds. They believe it's better. Also, education must be improved. Webinars, education. There is prejudice among the doctors that multiple injections is better rather than concentration. They can reach a better concentration. It's a prejudice. Of course, that's a myth which should be disproven. In the beginning, unless you remember. Vitaly, you don't remember, it's 20 years ago. The syndrome approach was not accepted. And also penicillin for treatment. So they still keep a post-Soviet approach. Therefore, we want training of doctors in parallel as we do, as we look for ways of solution, of registration of that drug. In parallel, there must be training among the doctors to remove that prejudice, that hospitalization and short-term penicillin is better compared to the prolonged one. Thank you very much indeed for this response. I believe that there is a lot of discussion, and those issues will be discussed. Our counterparts from WHO have heard of this problem. Thank you very much indeed. We move to the next participant.
Great. Thank you, Ludmila, and also for the great discussion. I think food for thought and moving that forward. And now we are going to have our last presenter joining us from, I'm not sure, she's European and an American, and maybe she's in France. But we are incredibly delighted to bring this 3-day meeting to a close before we have our wrap-up thoughts with the wonderful Sindra Fuhr. She's a senior program manager at AVAC. It's a New York-based advocacy group that many of you should know about. And she co-manages a number of advocacy programs in the US, Europe, and Africa. So, and she also sits on a number of steering committees, including PrEP in Europe, which I'm part of, and Gus Kearns and others, including Anton's. So we are incredibly delighted to have Sindra with us joining, because she's going to give us an overview about the pipeline of PrEP products. So we have a very active research pipeline. There's a lot of excitement about biomedical prevention, and I sometimes call it next generation PrEP. And Sindra has always done a wonderful synthesis of the topic in previous meetings. And that really was our motivation to ensure that she had the opportunity to speak to our participants. So really delighted, Sindra, to have you join us, and the floor is yours. Can't hear you.
Sorry, I was on mute. Let me unmute myself. Sorry about
Beautiful.
that. I was saying thank you, Giannis. I was saying I wish I could be in the Ukraine with all of you. That I just recently found out that my grandfather was Ukrainian. So that's exciting.
Cosmic connection.
Yeah,
wonderful.
It was meant to be. So today I'm going to probably give you too much information, but hopefully you'll get a nice overview of what's in the research pipeline. And when I talk about the research pipeline, I'm specifically talking about ARV prevention and why do we need alternatives to daily oral PrEP or to 211 PrEP, and what's the advocacy that we need to really get to move stuff from the research pipeline to delivering it to the people who need it. And I'll touch a little bit on alternatives, on other things that are not ARV based. Oops, trying to move my screen. Okay. So I don't know if you've talked about the failed targets from 2020, and I'm just going to draw your attention down to here that in 2016, UNAIDS did a survey of the globe and said 3 million people are qualified to be on PrEP, and we need to reach this target by 2020. And unfortunately, the number that was reached by the end of 2019 was 590,000 people on PrEP. I'm not going to spend too much time on this. This is just a global tracker that we do at AVAC, and we have every country and how much each country has initiated people on PrEP. And I guess the point is that we're now up to, after quarter one, we're up to 1.1 million as a total. We still haven't reached the 2000 mark, the 2020 mark. And you've talked a lot about the targets in Ukraine over the last 3 days, so I'm not going to go into that. But one thing that we see is that it's not enough to bring the access of oral PrEP to people. It's also very difficult to keep people retained on a daily oral regimen. And so albeit this is from Africa, but we've got female sex workers, MSM, young women, serodiscordant couples, and the general population. Not sure who that is, but you see from month 1 to month 6, you've got almost 5% of the people who initiated it have retained their regimen. So there's many reasons why it's hard to take a daily pill for prevention. Many reasons. So while we're addressing these reasons, science is moving ahead to work around the adherence issue. It's really, we call it the fancy word adherence. How to make it so that there's a PrEP that is acceptable with our lifestyles. And so what I'm going to focus on mostly today is this pipeline of new, as Anna said, next generation. And so these are just some examples. So we've got the pill, there's the vaginal ring, and I'll talk a lot about that today. There's injections, whether it's subcutaneous or muscular injections. There's a vaginal or rectal insert. There's even a film that you put under your tongue. And then there's an implant that gets implanted under the skin. Those are a few examples. Now, I know that this slide is oops, sorry. This slide is big, but I'm going to draw your attention to this box here for now. So these are the delivery mechanisms. So I was just showing you, we've got pills and films and enemas. So these are all of the ways to deliver the antiretroviral drug. And then here's the whole list of all the drugs that are being studied. And so we combine these drugs with these delivery mechanisms, and we get a whole buffet of different potential next PrEP generations beyond oral PrEP daily use. And so here, these are some that are in preclinical. For example, if we look at, I think this is cabotegravir. It's orange. I can't see because, wait a second. Oops, sorry.
You just need to maximize it a little bit, I think.
No, I think I need to get rid of my picture. Okay, there we go. So now I can see. So here we go. Here's Pfizer. This is preclinical. It hasn't gone into human studies yet, but they're looking at this in the lab. So this is just one example. This is an injection with Maraviroc. See, I move over here. And also I want to draw your attention. All of these are multi-prevention technologies. I heard someone today saying, people think that PrEP takes care of STIs and everything, but we are actually working, our science is actually working on a whole bunch of different multi-purpose prevention technologies that would actually prevent HIV, but also pregnancy and other STIs like herpes. And this is all really happening too. It's mostly preclinical. It's not in humans yet. And so here's phase 1, the early studies. There's a lot going on here. Phase 2, there's a lot going on there. But today I'm going to focus on the phase 3 and 4. And these are the late stage studies. And these are some of those that are even moving towards regulatory approval. And the reason why I want to focus on this is because we as policymakers, community, and implementers, we have to be aware of what's coming around the corner, because it takes a long time to prepare our countries. As we see from oral PrEP, there's so many lessons to learn around oral PrEP, how long it's taken to even get 3,000 people on PrEP in Ukraine, on oral PrEP. Meanwhile, there's all this stuff in the pipeline. So I'm going to spend the rest of the time mostly talking about these. So Depivarine ring, there were 2 efficacy trials, so big late stage trials. Results came out in 2019. It's a flexible silicone vaginal ring that is loaded with the ARV Depivarine, and it gets inserted in the vagina for a month. It's self-insertive. It doesn't interfere with sex, so the partner doesn't have to know. It's non-systemic, so it doesn't go throughout your body, throughout the bloodstream. It's just a local protection. Probably not great for injecting drug users. So the clinical trials, there were 2 of them. They showed that protection reduced risk. The ring reduced risk by about 35 to 27%. But then when they unblinded it and they did the open label extension, they showed that when people knew it worked, they used it more. They were less likely to take it out, and they used it more, and it was 50%. It reduced risk by 50%. And so it was declared the first long-acting HIV product. So what are their next steps? So they did this weird thing where the EMA, the European Medicines Agency, actually made an opinion that allowed it to then be it was a sort of umbrella regulatory approval for women in Africa. However, the EMA's approval doesn't apply to Europe. So if European women want the Depivarine vaginal ring, there's a lot of advocacy that needs to be done to get its maker, IPM, to actually file for regulatory approval in Europe. The WHO recommended it. That means that PEPFAR can actually buy it or implement it. And even the US is, so it's right now it's rolling out, regulations are rolling out in Africa, and it's under review in the US. And there's a bunch of more. This was the first vaginal ring. There's a bunch more. In fact, in phase 2, there's a 3-month Depivarine ring. So you would only have to change it 4 times out of the year. You keep it in for 3 months. There's all different ones with combination ARVs coming up. They're also using Depivarine in the film. They're loading it in a film in the gel. So next I want to go to what I think you've been I've heard it spoken about throughout this conference, is the long-acting injectable Cabotegravir. And this could possibly be a game changer, and people are very excited about it. This is there were 2 efficacy trial results that we just found out about in the last year, and they're still ongoing. They unblinded it. There's open label studies, but basically they stopped. They unblinded it early because they saw that. Let me just back up. So it's an intramuscular injection every 2 months. So potentially it's 6 times a year you get an injection, and you don't have to think about taking a pill every day. You don't have to think about HIV at all, because you're protected, the drugs in your body. They compared it to Truvada. The studies were done in gay men and trans women in the Americas, Asia, South Africa, and in women in Southern and Eastern Africa. There were no studies done in Europe, which is important because the first places that they roll it out will be hopefully be in the places where the trials were. And the results were beautiful. They showed that CAB-LA is as effective, if not better than daily Truvada. But both still, when you take them, both actually have very, very, very high rates of reduced risk by almost 100%. This could possibly be a game changer for all those people who can't and don't want to stay on daily oral PrEP or 2-1-1 PrEP. So ViiV, its manufacturer, said that they will file regulatory applications at the FDA, the EMA, and in Southern Africa. So again, they're going to do it first in the trial countries mid this year, and hopefully they could be rolling it out as early as 2022 in some countries. Where Ukraine fits in this, that's up to you. So far, they haven't been very transparent about a price, about how much it's going to cost. And as advocates, we say, well, there was modeling done, and they said that it needs to be as inexpensive as generic oral PrEP, or else it's not going to be cost effective to roll it out. It's also an integrase inhibitor, which can be a top-line treatment. And so for countries that have integrase inhibitors as top-line treatment, you might want to pursue alternatives of treatment, because this is also, it could possibly cause resistance in PrEP users who are using cabotegravir but are HIV positive. So again, advocacy to the manufacturer for regulatory approval in Ukraine. I don't know if Ukraine goes by the EMA or needs their own approval. Also, it would be good for ViiV to have a community advisory board with Ukrainian members on it if Ukraine really is serious about getting it out to their communities. PEPFAR could also be pushed to fund a CAB-LA pilot program in Ukraine. And then the typical advocacy for any new PrEP would be regulatory approval, enabling policies and guidelines, service provider education, service delivery channels, demand generation, and communications campaigns. So next we have, currently there are 2 efficacy trials of islatravir, which is a once monthly oral pill. There's one again in women in sub-Saharan Africa. And again, it's being compared to TDF-FTC. There's also one in gay men and trans women across the globe. This started this year. Results will be out in 2024. They're also in early phases looking at islatravir implant that would last a year. You put it under the skin for a year. It slowly releases this drug islatravir, and you don't have to take it out or think about HIV prevention for a year. That's a long way away from a daily pill. The next we have FTAF. I'm not going to spend too much time on this. This is another daily oral pill. It's exactly like Truvada. It's the same company, except for it's less drug. They tested it in gay men and trans women. They didn't test it in people with vaginas. The FDA did actually approved it for anyone who's not at risk of vaginal sex. We don't know if it is protective in women. So there is a study in South Africa and Uganda, and results will be out in 2024. Personally, because it's less drug, it might be good for people who have pre-existing kidney problems, but there's probably not a lot. It's not available in generic form, so I don't think it's that interesting to people at this point, unless they have kidney problems. There's lenacapavir. This is also in phase. It's a phase 3 trial that's being planned. It's a 6-month injectable, so you would have to just get a shot twice a year, and it's heading into phase 3 trials. Again, it's in women in Africa, and it's in men in the US and South Africa. it's about to start this year, and results will be out in 2024. And last but not least, there's the dual prevention pill, which is it will prevent HIV and pregnancy. So it would be a single co-formulated tablet with TDFTC along with hormones to prevent pregnancy. And it doesn't go through the traditional phase 1, 2, 3 R&D pathway. They're doing bioequivalence studies to see if a combined pill works as well as a Truvada separate from the pregnancy prevention. They think that they'll have enough data to file for regulatory approval next year, and possibly it would be out within the year from there. So I just gave you a bunch of data. This is sort of shows you the timeline again. So the vaginal ring, these stars means that it's possible for these to go to market at this time. So the vaginal ring is well on its way to market in Africa. The CAB-LA can be to your doorstep as early as 2022. The lenacapavir 6-month injectable, maybe in 2024 once the trials are completed. TDF, the dual prevention that prevents pregnancy and HIV, that could maybe be ready by mid-2022. The oral TAF would perhaps be ready in 2024. The islatravir trials, these might be ready again by 2024. And then we've got the HIV vaccine, which I'm just going to draw your attention. These are I know this is a busy slide, but these are the non-antiretroviral interventions. So right here, we've got the Mosaico vaccine. And this is actually happening in Europe for the first time. There's a phase 3 efficacy vaccine trial, and it's happening in Spain, Poland, and Italy. And results could be out as soon as 2023. So this is something to watch out for. And probably a lot of you have heard of the antibody VRCO1. We just had results from this. This is a passive. This is an infusion of monoclonal antibodies that are made in the lab. So instead of getting a vaccine and having your body respond to the vaccine by making antibodies, this is just an infusion of antibodies that can prevent and kill HIV. And we just had proof of concept that it can indeed work. However, it only works against certain strains. So it's still in the lab, and we don't know how scalable it is, but we're learning a lot in this realm. In conclusion, more safe and effective prevention options are entering the market and in development, as you could see. But right now, TDF-FTC is our only PrEP option that's widely approved and with clear programmatic guidance, targets, product availability, etc. But now is the time to integrate the Dipivrian vaginal ring and the CAB-LA long-acting injectable into prevention programming. Now is the time to also prepare for late phase pipeline products, the other ones that I talked about. No one option will be the choice for all people all the time, or for one person all the time. And with that, here's a bunch of resources, and thank you very much.
Sindra.
Yes.
That really was just a wonderful overview. Sort of rapid, comprehensive. And we have actually a bunch of comments in there. I've added some comments. I just want to take a stab and give you a question in terms of maybe your feedback also as an advocate in getting, WHO advises countries in around policy and then shaping programs. But we do have to also think about, as we think about scaling up oral PrEP, what it may be a sort of an additional new product that can complement our efforts in, driving down new HIV cases, and could be even more efficient than, taking a pill every day. So you made a comment about how maybe a community advisory board could be kind of set up in Ukraine and other countries to, engage with ViiV, the manufacturer of CAB-LA, and also regarding the Dipivrian ring, where the focus has been always sub-Saharan Africa, but we do have, I think, concerning and appreciable levels of HIV transmission in cisgender women in Ukraine, and so they could benefit from an additional option of this product. So maybe just some of your thoughts from an advocacy perspective for our audience here.
Yeah, I mean, what we see in the contraception world and what we see in the prevention world is that the more options available, the more uptake in general, and the more people are protected. I think the Depivirine ring one because it's 50%, it reduces risk by 50%. I guess that's better than nothing, but not as good as oral PrEP, right, or cabotegravir injectables. But if someone doesn't want an injectable and someone doesn't want the oral PrEP and they'd rather have a vaginal ring that's topical, the only one that's not systemic, the only one that doesn't put drug into your body, it should be made available. What I see, there's a tendency for countries in Africa to say, oh, we're not going to try to scale up oral PrEP or Depivirine ring. We're going to go straight to the cabotegravir. Because it seems like such a sure bet. But I think the idea is to really make sure that as advocates that there's options, because we can't speak for everyone. We don't know what the next person wants. I don't know if Ukrainian women will or won't use a Depivirine vaginal ring, but giving them the option is all that I can really fight for.
Great. Really appreciate everything you've described to us. And I'll pass it off to my colleague, Vitaly, because we have to pass off to our colleagues at PHC. Again, thank you so much, Sindra. Let's keep the conversation moving forward and educating, informing the public about next generation products. Thank you so much. And stay well.
Anyone who has questions, please get in touch with me at AVAC. Yeah, here, I'll write my
Thank you so much. Thanks. I appreciate it. Thank you. Now over to you, Vitaly.
Thank you very much, colleagues. So we reached the closing moment of our 3 days conference with international participation beyond regular protection, and we have a 10 minutes so-called summary as to 3 days of work, and would form thesis of what was voiced out of the topics that have been discussed. And Larissa Getman from Public Health Center will present the draft resolution that was developed and will be distributed among all the key among the groups, participants, and organizers to distribute among all the colleagues, all the participants. So please switch to the panel. Yes, for the joint discussion. So, colleagues, we reached the final point of our conference. Yes, it was really very, very tight work with lots of ideas. And so we decided to develop final documents, incorporating all the best ideas and how to promote PrEP in Ukraine. So I would like to ask to share the screen of the document, and I will omit the introductory part. And I would like to come directly to the body text. Yes, here, please. So we participants of second on PrEP beyond in regular protection, we again evidence our adherence to PrEP in decision of the WHO and General Assembly of of the decision to eliminate the inequality. No sound. No sound. No sound. The mic is off. And to eliminate AIDS till 2030. It's like blurring on my screen. I can't read it. Can I scroll it myself?
Це залежить від якості з інтернету. Я не бачу повністю.
It depends on the quality of the link, of your own link to the internet. Unfortunately, not ours.
Дуже добре видно зараз.
Yes, it's really, we see well, yeah. Well, there was some technical issues, in particular, governmental leadership. So we have to support and develop governmental leadership or public leadership in the sphere of PrEP, of HIV infection, on the basis of the broad society together with professionals and scientists to introduce the PrEP on the all national level, include the indicators on PrEP in the program of medical guarantees. Providing this sustainable financing to PrEP, to reduce the donors' financing, and so with legal support, governmental management of prophylaxis program, on the key targeted on key population. We should provide the sustainable services and effectiveness of PrEP through systematic and timely review of the strategical national strategy. We have to actively include the representatives of the key groups to the work on scaling up the PrEP, including the national regional coordinating mechanism. We have to reduce stigma and discrimination among medical professionals concerning the key groups through the constant informative and educational work on a gender-oriented approach. Implement PrEP services for key groups basing on on community basis, and take into consideration the characteristics of every group, using principle peer-to-peer, and maximize the quantity of services and combine them like on a single point based system. Strategy and strategical decisions. So to provide access to innovative PrEP drugs, taking into consideration the cost effectiveness. They diversify the models of PrEP provision for different vulnerable groups. To implement the demedicalization model for PrEP for different vulnerable groups, to integrate model of the uninterrupted quality improvement altogether with public healthcare facilities and NGOs to develop information support and acknowledgement campaign on the basis of commercial marketing and using the online and internet to provide for additional technical consultations for PrEP implementation among PWITs, systematically increase research potential on national regional levels through up-to-date studies and using modern technologies informing the demands, recruiting, and so to develop same-day PrEP. These are the proposals, combining all the ideas and theses that have been voiced during our conference. The initiative group, initiative working group, will review and finalize the draft document, and we will distribute this document among our participants. So we are at the very end of our conference. These were 3 very active, very interesting days that served as a good step, as a good stimulus to even for us to be more active in all our areas of work. And when speaking just pre-exposure prophylaxis, this embraces all other and more diversified aspects, namely in the area of scaling up the PrEP. Unfortunately, COVID-19 prevented face-to-face contact, but I think that we will have the opportunity to see ourselves offline, and also to be even more enthusiastic about PrEP in Ukraine. And now I give the word to my colleagues. I appreciate everyone's effort, speakers of the working group, to our international project partners, and big thanks for their support and assistance and help. My big thanks to the organizers, technical support group, interpreters, to our moderators, and once more, see you next time in 2 years in Ukraine in offline settings, I hope. Colleagues? My big thanks, colleagues, for these intensive 3 days of work. My big thanks to all the moderators, to organizers, to technical support who managed to prepare everything in a very short time, to the interpreters, and also we have links to all the presentations on our website. We will upload all the presentation. The major part of them is already posted on the website, and yes, we have really a very bright the closure of our conference, and
У мене буде моє маленьке кохання.
У мене будуть нові досягнення.
a very productive work. Thank you. Thank you very much. Thank you very much for the invitation, colleagues. And thank you for
У
participation.
мене буде моє маленьке кохання.
У мене мене будуть нові досягнення, тому що мрії здійснюються. За умови ефективного лікування ВІЛ не передається.
Це найромантичніше побачення. З тобою цінуєш кожну мить. Бо за умови ефективного лікування ВІЛ не передається.
Так круто відчувати усі барви повноцінного життя. Кохати, народжувати, мріяти. Бо за умови ефективного лікування ВІЛ не передається.
Понад 100 тисяч ВІЛ-інфікованих українців уже приймають АРВ-терапію. Лікування безкоштовне та конфіденційне.
У разі досягнення невизначального вірусного навантаження ВІЛ не передається.
Головне – не переривати лікування.
Зроби лише один крок. Не дай ВІЛ зруйнувати твоє повноцінне життя.
Сьогодні він з нею, завтра з ним, післязавтра з ними. Макс не обмежує свої бажання, але розуміє, що ніколи не може бути впевненим у випадкових партнерах. Тому Макс обирає доконтактну профілактику PrEP. PrEP – це таблетки, які не дають вірусу інфікувати організм. Їх приймають щоденно або ситуаційно до та після статевого контакту. Всесвітня організація охорони здоров'я рекомендує PrEP людям, які практикують незахищений секс, мають кілька сексуальних партнерів або партнера, який живе з ВІЛ. Завдяки PrEP Максим залишається здоровим та має свободу вибору. Він думає про себе, про нього та про неї. Подумай і ти. Обери безпечне життя зі свободою вибору. Захисти себе та інших. Зателефонуй на гарячу лінію з питань ВІЛ-СНІДу та завітай на сторінку Центру громадського здоров'я.